World Health Organization Collaborating Center on Social Determinants of Health and Health in All Policies. We're glad to partner with Professor Luvengo in this dialogue around a topic that he's very passionate about, the learnings from the first, second, and third waves of COVID-19 pandemic in South Africa, especially from the perspectives from frontline healthcare workers such as him, who have been really at the front line of this pandemic. I would like to extend a special word of welcome to our Minister of COGTA, who also leads us in the health, education, and science and technology work, Dr. Nkosazana Dlamini Zuma, our MEC for health in Limpopo, Dr. Popi Ramatuba, and representatives also from the National Ministry of Health, who was also assigned to participate on this platform, colleagues from all walks of life, especially in the health sector, from academic, district sector, from management. You're welcome, and I present to you the clinical head of surgery, Department of Surgery at Wits University, who also works at Charlotte Maxeke Hospital, Professor Tifeli Luvengo. Over to you, Prof.
Thank you very much, Dr. Gwen Ramkupa. Thank you to everybody. The introductions have been made. In the interest of time, I'm just going to provide some guidance and a background of why this meeting. I have been driving trying to prepare the CMJ cluster for NHI, and then when I was excited and I was then asked what is happening with COVID, I told my seniors that, hey, with COVID, we on the ground have given up. This thing, the third wave has been so bad. And then I was asked, as if you are giving up, what is going to happen to the public? Is it not possible to arrange a meeting for people on the ground who are directly involved to actually present the learning? Because we thought we learned a lot from first and second wave, but the third wave, I think we sort of gave up, and the mortalities are very high, and admissions. And there's a fear that if the fourth wave comes, we are probably going to be worse off again. And when I asked myself to say, what is it that I can provide or guide government? What is it that I feel could be done better? For example, I would say perhaps we waited for too long to have a definition of a wave before we acted. And other countries would respond to 20 cases as we waited for 2,000 or 3,000, whatever, or a certain percentage of positivity. And that other thing that I thought was a problem was the results. You know, we tend to get the results after 48 hours, after 72 hours. And I said, perhaps when we are preparing for the fourth wave, if we can't prevent it, maybe the results will be early. So the purpose today is not a morning section. It's for us to say, here, the leadership is here to listen to you, coming up with what did not go as well, what went well, what could be done better, so that we reduce the mortalities, so that we, if it's possible, we prevent the COVID, the fourth wave, and we should be ready in preparation for any other disaster. The last thing was to say, there's a lot of learning that we can take over in preparing the ground for NHI. what is it that we feel as healthcare workers? Because health belongs to us. We are the ones who should make it right. We can't give up. The community is looking after us. So that's the basis, strictly 5 minutes, strictly guidelines, and we are not going to cut you off unless if you go way over time. But we're just asking, don't tell us government is corrupt, government is wasting money, government, there are no whatever. We're saying all of us are leaders. We are here to provide that leadership. So I'm going to ask, we're going to co-chair with Dr. Gwenda Mukhopa, and I'm going to ask the first person to speak would be Professor Pele Mulaudzi, who is the head of pediatrics at Charlotte Mateke, University of Witwatersrand. Thank you, Pele. Take over.
Good evening, Prof. Lubengo. I've actually lost my voice now and my thought and my chain of thought, but I will try to be in that 5 minutes and have heard what you have said. And all protocol observed with all honorable ministers and members and colleagues in this meeting. As I was asked, I had to really think about what is it that I can say in 5 minutes in the whole time that we have experienced all these waves. And I have opted to look at systemic issues that we should think about to be able to provide the better services and direct the way in which we should respond in this manner. So I have few points that I want to say I have learned, but at the same time, mixing with what I think we should do. And seeing that I'm a head of the department for pediatrics and my specialist base is pediatrics, the one thing I'm going to mention in that aspect is that despite the fact that we say maternal, neonatal, and child are a high priority in the country and form part of the four burden of disease that has been described. In the planning of it, they actually remain in the background. And therefore, we find that number of things that are supposed to be done, in particular for those maternal, child, and neonate, remains in the background. And particularly in this disaster, where actually the main number of that. And in that aspect, I would like to say in going forward, we should be able to actually protect the essential services and also sensitive services, and so that we can continue to provide services that is necessary and not lose the gains that we have made. And where there are advocacies, you do get to hear about those. And for example, just to mention in our learning, is that in the repurposing of finding ways in which to deal with COVID, certain essential interventions for children actually were not considered, or in some time were even taken away. We know that the hospital's KMC services were taken away, and we should be protecting those interventions that we know they actually are important so that we can improve and not have many losses in those. I'm just using the KMC as one. The other one that was not protected at all was the fact that we understand that in managing, you co-manage with parents. You don't manage alone. And in that aspect, even in all the things that came out regarding visiting hours and all the ways in which we should manage, you had to find yourself at the back foot to say, it is the parent I co-manage with. It's the parent I tell what is going on with the child. It is the parent who actually is the one who will continue to manage, unlike an adult who knows what they were doing to them and what needs to be done. So the thing that is there is that as in system-wise, we should protect essential services. And therefore, the second part of it is that with that, we should also not only talk about first wave, second wave, and preparation for the fourth wave. My second one in the points I want to make is that we should start talking about how do we provide services during the COVID pandemic, so that the essential services that needs to be there are important. And therefore, going forward, our plan should not be preparedness of only the fourth wave, but I think should have these elements in it. There should be plans that are truly specific for the COVID response, but there must be plans that are important about allocation of the resources for the services that are essential, and that should continue during that time. And the plans should also talk about what adjustments are being made for the routine services that needs to be done. And in particular, those routine services that should be, we say, during the peak, we may forego them, but in between, we must make sure that we catch up with them. How we had to shift and how to deal with patients coming with testing. And if you go around with many hospitals, you'll find that they have an outside tent in a way to actually be able to accommodate screening and testing and all that before they could go that. And therefore, it is essential to define what are the essential services in that aspect. And also to also say that within those plans, what I have learned has been that we have been very hospice-centric. And in a way, we have done all these plans, we have actually not put much effort in preventing and promoting. And those non-pharmacological interventions that remains important in this point needs an even more vigorous work, so that people don't think that because we now have vaccination, we should actually. So in a way, we need to move back, and also in doing prevention and promotion of what needs to be done, strengthen the primary healthcare services to actually be doing much of the work. COVID places or COVID hospitals, that we come to a place of saying we would, in each of different levels of care, there will be what needs to happen in this. And with that, the primary healthcare centers should actually also be able to do the testing and to actually do the tracking and of the at least reduce more numbers of people that could actually be infected if we have really made our time to deal with the promotion and strengthening of the primary health care. I see my time is up. Thank you.
Thank you. Thank you very much. I just indicate there are quite a lot, because we had opened a Microsoft team. Apparently the members are joining the Microsoft team. Please advise them to move over. Can I ask Dr. Peto Mangena from Polokwane, Mankweng, representing Limpopo, what is the experience?
Good evening, and thank you to Prof. Luvengo and Dr. Ramohopa for this little space to reflect on our experiences. I would like to start really by paying tribute to all our healthcare workers because the predominant theme is that our healthcare workers have shown resilience and innovativeness in dealing with the pandemic. Now, despite the very high mortality that we've all witnessed, which has brought on emotional trauma to all of us as healthcare workers, and in the midst of feeling anxious and fearful for all our personal safety and the safety of our loved ones, the healthcare sector as a whole has at least managed to keep the wheels turning. Clearly, there have been errors, some balls have been dropped, but on the whole, the system has managed. And by the system, I don't mean abstract matters, but rather the people themselves working in our healthcare settings have tried to keep things going. Although we did bend, and for some of us or many of us, we came close to breaking. We've found ways to be innovative, for instance, in working in multidisciplinary teams, customizing the types of shifts that best provide care to our patients, and finding ways to restructure the sites that we all work in to accommodate testing and vaccination, as well as having separate areas to manage the infected patient away from the non-infected patient. As much as we talk about resilience in these healthcare workers, it's very important that going forward, we should not take our healthcare workers as well as their resilient resources for granted. We've often heard that public workers are overstaffed and underproductive. But I think I can't think of anyone who would claim that they were overstaffed in the course of managing this pandemic. It's important in looking after our healthcare workers to take serious proactive steps to try to manage their mental health. And whilst a lot of our provincial health departments and private organizations may have some generic employee assistance programs, we do need to think specifically in terms of healthcare workers who, for instance, work very long hours, even outside these major peaks of the pandemic. We need to also consider the constant exposure to trauma, both the physical trauma that we see as well as the emotional trauma, for instance, dealing with child abuse victims and sexual assault victims. So we need to think how we can better support our healthcare workers, because without our healthcare workers, we do not have a healthcare system to speak of. And maybe we should be considering, for instance, an option such as a mental well-being day off for each healthcare worker, which can be taken at any time over the course of a calendar year. A second point is there's clear proof in how this pandemic and the response to it has unfolded, in that has shown that where there's a will, there's clearly a way. Now, in the last 18 months, there's been a lot of political and economic will, which has led to some successes. Most importantly, globally, we've managed to produce a vaccine within 12 months of identification of a causative organism, which is something that many scientists thought was at all. We've also seen in our own country, business and government collaboration, such as with the National Ventilator Project. And there are lessons that we can take from this. I'd be interested in seeing how our country can combine some of our industrial and engineering know-how to solve some of the big challenges that still face us in healthcare. So by exploiting some of the technical knowledge and expertise in this country, why can't we, for instance, increase the availability of homegrown ventilators? Is there a way we can rely on our engineering sector to help us build cheaper dialysis machines? Because that is something that continues to plague our healthcare sector, is a lack of resources due to a reliance on expensive, important equipment. Further, derived from this sense of political will and economic will driving good outcomes, we've seen how equipment has been rolled out and infrastructure has been improved in a very short space of time. Now, many of us working, particularly in the public sector, may be familiar with the glacial speed of procurement and supply chain processes, where it can take months to stock up medication or to access new pieces of equipment. And we can see how in only a couple of months, we were able to rapidly improve our healthcare infrastructure. For instance, in rolling out oxygen delivery mechanisms, as well as distributing high-flow nasal cannula devices to all sorts of hospitals. And once again, that's a lesson that you can take forward. There are many hospitals outside of our major centers.
But I think what we are going to do,
yes,
we are also going to, this meeting is the beginning of several meetings. And because there's a lot that you need to, and also a written submission. For the start, the leadership has just said, let's have 5 minutes and we're going to expand it next time. But I'm not, I'm just saying what the last minute, if you can just say something quickly.
Okay, I understand the time limitations. So I think that was a lot of what I wanted to speak about, but also to say we've learned how to use technology in ways which enhance communication. And that is something we can build on in allowing communication within facilities, but also across the country. For instance, academic leaders in academic centers being able to communicate with those in smaller hospitals across the country. I think I'll leave it there, Prof, because of the time limitations.
Yeah,
okay.
But we will ask for a written submission also. Thank you very much, Petro. I think Limpopo is proud of you. The next speaker is Professor Mervyn May, who is the head of critical care at VETS. Prof.
Good evening, everyone, and thank you very much for the very kind invitation. And Prof. Luvengo, thank you for really triggering all of this and putting it together with the wonderful colleagues here. I am going to see if I can, in fact, share some stuff with you, and I won't take very long. I think there have been a lot of negative issues that have come out of things, and we have to sometimes look at positive elements. And I hope that I can in fact share some positive elements with you this evening, and also things that I think we ought to in fact consider. Please let me know if the screen.
I've just, Prof, I've just given you rights for sharing. If you can just see if you're winning, if at the bottom there, that arrow, you can just click.
I have, are you able to see this?
Nothing as yet.
Okay, maybe I had preempted that, so I'm going to try once again. I'm going to close the presentation, and let's try once again. So share the screen. If it doesn't work, I'm happy to talk you through it. Are you able to see anything at this point?
Nothing as yet, Prof. I think maybe you can share, and then if maybe you can just put it as a file, and then I'll see if I can be able to share on the chat group and just edit as a file.
Not a problem. What I can do is I can walk you through this. I think there are just a couple of points I want to make, but also elements that I think are particularly pertinent for everyone, and obviously hugely relevant for my own field, in other words, critical care. So I'm going to touch on a couple of things. What has the last 16, 17 months been like? What about preparation? How relevant is it to communicate? What about staff protection? What about challenges and opportunity? We work in Africa in a resource-limited setting. What about simplicity? And really important, I think, that we all have to take out, and it's something I've shared on fora, including in the WHO, European Society of Intensive Care Medicine, World Sepsis Congress. Being poor does not mean poor care. And I think that's a very important issue to take out. I want to touch very briefly on flexibility, what all of this has meant to the profession, that we're so privileged to be in, what it's meant for critical care, and how ultimately we can all make a difference. So if you said to me, could you describe the past year to me? As someone who enjoys words and terminology, it's been taxing and tantalizing. I think it's been eerie and enthusing, intrusive and illuminating, demanding and distinctive. But it's been rewarding in a time that's required reflection. It's why we're chatting this evening. And I think there are multiple lessons that we've all learned to take out of COVID-19. The first is that preparation's pivotal. And in fact, recognizing that certainly in our setting, right at the beginning, sort of in December, January already last year, we had our first meeting. And maybe that was because we were worried that something may unravel from the story we were hearing in China. And maybe it was because we are a referral center for viral hemorrhagic fevers, things like Crimean Congo, Ebola, Marburg virus disease, etc. And literally, right at the beginning of last year, we got all the representatives from all the relevant divisions. So from the epidemiologists to the infection control people, to the microbiologists, to the critical care people, to the Department of Medicine, to the nursing staff, to security people, to the kitchen people. And we actually had our first meeting. And after the first meeting, before we'd had our first patient in South Africa, we had a working protocol. And I think that protocol has been widely disseminated now and in fact has been refined. The second important point I want to make is communication is paramount. It's absolutely essential as a component in all interactions. And in fact, with the fear, the panic, the anxiety that in fact was emanating, it had to be engaging, constructive, polite, and inclusive. Dictatorial communication doesn't work, not in my book. It's always got to be inclusive. And in fact, what I set up in our unit, where we had nursing staff that did not want to get involved, where we had administrative staff that did not want to get involved, and I speak only for the ICU, and medical staff who were very, very fearful. I set up a daily interaction. I prefer to term it that rather than a debrief, and everyone was allowed a voice. And once everyone had expressed their voice, and we did this every day and every night for the first several months, all issues were openly addressed with respect and with tolerance. And in fact, everyone aired their views, and it allowed us to institute and make decisions that we could do definitively. The staff felt backed and appreciated. We could go about our things with passion and purpose. Others followed. And in fact, from having no one wanting to work, we actually had volunteers for extra work. And when we started getting patients, we made sure that families were not excluded. And we were amongst the first people to video record and make sure that every single evening there was communication with family members. Staff protection was paramount. And I think I can share with you a figure that you will probably see coming out in the next 10 days to 2 weeks about the number of healthcare workers that have sadly succumbed to this pandemic. And certainly before April, that number was around about 783. And after April, that number is certainly less than 100. And that is the impact probably of vaccines and better ways of protecting our staff. And we instituted every single day, and I insisted until it was coming out of their ears, until the staff were dreaming about it, proper PPE, in-house training. And what we did was eventually adopted by others. I thought that the initial national guidelines were not adequate. And once we'd in fact got on top of all of this, in fact, we had very, very few healthcare worker, if any, infections. And this was exemplified by absolutely vigilant infection prevention control measures. Now, for me, one of the biggest lessons that we can all take out of the last 16, 17 months, in fact, 18 months, because it all starts before, is that challenges also present opportunity. And I was approached up front about the creation of field hospitals and how we're going to look after these critically ill patients. And everyone was seeing what was unraveling around the world and streams of patients on ventilators and so on. And I looked at this and I said, but in South Africa, there's a reality. There are only 70 to 80 critical care specialists in the country that have been trained. Half of them don't practice critical care. So we probably have 35 to 45 full-time critical care specialists. How are you going to manage all of these things? We don't have ventilators, we don't have thousands of ICU nursing staff, and we don't have the beds. I mean, bed numbers that were bandied about were in the region of 7,000. The only hard data that we had was from a Critical Care Society of Southern Africa audit, which suggested there might be in the region of 4,500 beds, and only 1,100 of those beds effectively were state beds. Now, those numbers were pushed up a little because the audit was done some years ago, but that was the reality in South Africa. So my idea was to, in fact, optimize what we had in our own facilities. So we, in fact, engaged with social responsibility partners. And within 6 weeks, we had more than doubled, close to trebled our ICU capacity, entirely funded independently. It was done in 6 weeks, fully equipped, and we were able to actually accommodate the burden of disease that we were faced with. At the same time, recognizing that you need nursing staff to do this, we started our own nursing upskill project. And we had nurses by the second wave of this pandemic who'd been nursing in old aged homes before we were looking after ventilated patients. We arranged for ventilators, and I think one of the major impactful issues that we were able to introduce and help design were these so-called wall CPAP devices. Now, the preceding speaker spoke about high-flow machines. The wall CPAP devices cost about 15 or 1600 Rand. A good high-flow machine costs 60,000 Rand. And in fact, the CPAP potentially is much, much better. We in fact saved countless lives utilizing these, and they were disseminated around country. And for me, one of the biggest issues of creating an expanded facility was twofold. Number one was to allow us to accommodate a greater number of critically ill patients, and we were able to do that with appropriate triage for the most deserving patients and really accommodated the vast bulk of those. In between the waves, we were able to maintain that capacity. So we were able to take on patients who would never have ever had an opportunity of coming to ICU. Big surgical cases, cancer surgery, complex hem-oncology patients who would have died in the wards, complex medical patients, advanced HIV patients with diseases who would never be considered for ICU, and many of them had very successful outcomes. And looking into the future, for me, this was the way to go and is the way to go, because the benefits will accrue over time and they will be retained for many hundreds and thousands of patients in the years to come, because these facilities will be maintained in-house rather than a field hospital that is broken down thereafter. The other issue for me was to look at things in a simple way, in a pragmatic way, and adhere to basic principles. If you do the simple things well, you generally have good outcomes. Good clinical acumen is what we rely on, and we need to do that. And sound practice with excellent quality care is both feasible and possible. And I really want to emphasize that excellence is possible in the face of adversity. And so the story of doing more with less is an issue that we do have to just spend a moment on, because you don't want to do less for more. Don't stretch too much, because then we in fact miss what we are doing. There was a lot of creativity and innovation which we can share in subsequent fora. In fact, we were amongst the first people in the world to use corticosteroids based on local work on varicella pneumonia. We were the first people in the world to say, open the windows. You don't need fancy negative pressure facilities. You get great 6 to 12 air exchanges a year, an hour. And in fact, based on that, we had very limited healthcare worker infections. Proning patients, if they're awake, you don't need to put them on their tummy. What's wrong with standing them up or sitting them in a chair? Get far better expansion of the lungs. And from the southern tip of Africa, we were able to share these in-house concepts around the world and in fact, in some instances, change management. And we also were aware that we had to provide a facility for non-COVID patients so that they were not denied. We were flexible along the way. No one is a COVID expert, and we need to recognize that, and we continuously learn all the time. And there were many other intrinsic critical care issues like ventilation and so on that we were able to really get to nuanced forms, airway pressure release ventilation, and really change outcomes significantly. Finally, I think what this has shown is that it's a privilege to be in this profession. This is what these COVID-19 patients have taught us and emphasized every day. And for me, one of the best things is that it's brought to the fore the relevance of critical care, a neglected issue, and now what has been described as a scarce human resource. And kudos and acknowledgement to all the champions there. And finally, it is critical to care, and we need to do that with the spirit of Ubuntu, with humane and compassion in the way, both for patients and with our fellow staff. And we can make that difference. So I'm going to leave you with that, and thank you for the opportunity. Yeah.
God, thank you very much, Prof. This is the leadership is seeing. This is a very passionate person who has led.
Thank you very much.
Thank you, Prof.
I think Prof does have a difficulty, but we want to thank you, Prof. May. Indeed, innovation, but also human solidarity. I'm going to ask Dr. Liz van der Merwe, the head of critical care from Livingston Hospital in PE, to also share. We were informed, Dr. van der Merwe, that you were so relieved that you were not forgotten in this platform. This is your chance to share. Dr. van der Merwe. Are you there? Okay. Can we try, Siviwe?
Yes, I'll see what I can do with Dr. Liz. I think there's someone whose mic is on, but I'm just trying to see. I'm not sure. There's a bit of a negative feedback. But maybe we can go to the next speaker, Dr. Gwen, and then I'll just see how we can get Dr. Liz.
Thank you very much, Dr. Miller. Can I call Dr. Emmanuel Taban, who's a pulmonologist in the private practice? We also picked up that you are communicating, you're trying to get feedback, and it seems like the communication is getting lost. So Prof. Luvengo felt that we should extend this platform to you to share with us, having been in the forefront of caring for patients and your experience in the private practice. Dr. Taban? Dr. Siviwe, is Dr. Taban in the panelist platform?
So he's currently not on the panelist, also with Dr. Liz. I'm just trying to see how we can get those two. Maybe we can move to the next one. I'm so sorry about that, Dr.
Just let me.
Yes, I'll let you the moment they're on. Thank you.
Okay. Back to Charlotte Matleke, the head of pulmonology academic at the Charlotte Matleke Academic Hospital. Professor Ishmael Kala, are you on the platform? it's a new normal as well to be on the platform. Okay. I know definitely Dr. Sikole is there.
Yes, I know, sorry, Prof. Kala was also having difficulties, I think, with the link, but as soon as those three are on, I will revert to you, Dr. Gwen. Maybe we can go to Professor Gwen.
Okay, thank you, Dr. Miller. Dr. Sikole is the head of ENT at Witbank Hospital in Mpumalanga. Dr. Sikole, please unmute your mic, and if need be, you feel comfortable and you won't have a problem with the connectivity. Can we also see your video? Thank you, but over to you, Dr. Sikole.
Good evening. Thank you, Program Director. I seem not to have the video on my side. I also had slides to share. I don't know if I can be allowed to do that. There are just 3 or 4.
Yes, Dr. Sikwele, just click on the share option. You should be, all the panelists have been given rights to share slides. So if you can just click on the arrow at the bottom, you'll see there's an arrow that says share screen.
No, it's fine. I can't seem not to find it, but I've also shared this with Prof. Luvengo. Maybe I can share it with you. I can't seem to find the share option, but it's fine. I can also just go through it. It's okay.
Yes, I think feel comfortable to go through it, Dr. Sikole, and we will put together all the submissions. If they are also written, it would help, because we want this to be a part of, learnings, not only for ourselves here, but for the country, and maybe even the sector will share globally this experience. Please go ahead.
Thank you. Thank you so much, Program Director. Colleagues, professors, political leaders, MSs, and Honorable Minister, good evening. As said, I'm Dr. M.J. Sikole, the current head of ENT in Witbank. Quite surprising, how did I come involved so much with COVID? I'll just give you a brief overview of what had transpired in the province, the first, second, and third wave. So what we did with us, we formed teams at different levels, tertiary hospitals, district level, and primary health care, which ensured that there's operational management and coordination of systems in terms of COVID training, PPE recommendation, screening and testing, infrastructure, equipment, staff complement, SOPs, policies, and guidelines, research, and vaccination. So these teams were formed at primary, district, and tertiary level to overlook at all those things. Unfortunately, at district and primary healthcare, those were the challenges. They were not properly coordinated. And as the Professor Mlaudzi has said, we still have patients that come from primary healthcare center that come into tertiary level to do just a COVID test. And also we found that we have had a bit of lack of support from province and national. So we still encourage that if we can form these teams to overlook this COVID, and with enough support, regular meeting, we'll have a coordinated capping of the spread. And this will also improve in our service delivery and our referral system, both up and down referrals. In terms of training, we trained all our staffs, from the security guards, porters, to doctors and nurses, and everyone who work in a hospital, in respect to screening of patients, testing, and testing criteria, donning and doffing, which comes close to my heart. Second, to lack of PPE in the first wave. One of the other things which has improved or it has increased in healthcare workers being infected was poor training in donning and doffing, waste disposal. And we also had a clinical care platform that we formed with huge attendance in the first and second wave, which was online. We discussed, just to mention the few, management of exposed healthcare workers, treatment of COVID, and ventilation strategies, anesthesia in the context of COVID, surgery in the context of COVID, wellness and vaccination. And I had a panel of specialists that were coming from Limpopo, Gauteng, and to other provinces, and as well as Professor Nati Mdadla was part of my panelist. I think this should be encouraged. As the doctor from Polokwane, Dr. Peto, spoken about it. It's one way to speak to all the other hospitals, districts, or even combined national hospitals to share this information. The challenges that we have was obviously attendance, because this was not compulsory. And then we also had poor attendance between the waves, which we discouraged. Yeah, if this could be provisional driven, because it was mainly hospital-based, tertiary and district driven, we think that if it's provincially or nationally driven, we could have improving attendance, as training and learning about a disease, it's the core and the basis of fighting and winning this war. So we try and we recommend that if this could be part of standard practices across provinces and districts, would be better. In terms of screening and testing, we discussed screening of patients, or rather we taught staff in terms of screening of patients and staff members, discussing admission criteria, PUIs, isolation, contact and contact tracing, de-isolation and compensation, so that everyone is at the same level. Whether you are a cleaner that has been infected, what are the steps that you need to do? When do you come back to work? We taught them all those things through training online. The challenges that we have in terms of screening and testing is obviously the lack of testing kits across the province. The results in terms of PCR with us, it takes about a week. So I had people saying 2-3 days they are lucky. And then we only had a repeat test. I think it was once off in the second wave. This has caused a lot of delay in staff returning to work, a lot of delay in triaging patients in our triaging center, and a lot of delay in surgeries. So we pleading that if we can have these test kits available, repeat, and also we would like to move on with across the hospital universal testing, which is difficult for us now because we have to wait for the PCR results, which takes about a week. Then it defeats the purpose. In terms of the infrastructure, it's still a problem in Mpumalanga. Screening is done in our ER centers where all patients are just combined, high risk of infections. We plead that if we can have those tents that are well marked and well demarcated, and even in our tertiary hospital, Wheatbank, we don't have that. It's still a challenge. In terms of the COVID ward, we do not have a designated COVID ward. We just made shifts. As a tertiary hospital, we have a 40-bedded unit which caters for all PUIs and COVID confirmed patients with only 7 ventilators. And for a tertiary hospital, I think this is too small. In terms of theater, we have a lack of theater time and delayed in specialized operation. The hospital capacity, like I've said, is extremely poor. We had overflow even pre-COVID. So you can imagine with increased number of COVID patients, the overflow is even worse. So there was a point where we discussed issues of a field hospital with a visit from national, but it seemed to have died, and the discussion took around in the first wave. We will plead that we can have either extension or a field hospital in our centers, as we never had any of those in our provinces, and we get to be frustrated when we are at ways. In terms of staff complement, just the last slides. I think the issue has been said before, but we still have much more issues in terms of doctors. We currently have only 2 physicians in the whole province, and then 1 pulmonologist, thanks Dr. Tabang, does make time to come and visit us. Our COVID wards are manned by rotational ComServes, which this pose a challenge in service delivery. We end up having physical burnout, mental burnout, poor outcomes, and poor service delivery. So if possible, we can hire more specialized nurses and get COVID doctors on contractual basis, and also more medical officers. We've got ComServes that are currently not working, they are jobless, and these are people that maybe we can hire as medical officers, specialists, and also sending medical officers to benchmark how things are done in other provinces as well as other countries such as US and Europe. We recommend that. In terms of research, we currently have 5 researchers that have been submitted to Sefako University. Those were looking at first wave, common symptoms, epidemiological profile, risk factors, longevity of antibodies, post-COVID, and side effect of J&J. This also could have been long published. We had delays. We don't have a provincial ethical committee in Mpumalanga. So this has resulted in delayed publications, treatment recommendations. So we highly request support in building those ethical committees, and then also supervisors from professors from other universities, if they can come and help us, we really appreciate that. And we also plead that if possible, we can reinstate the collaboration or joint post with the universities. I thank you.
Chair, you're muted.
Thank you. I'm done.
Chair, unmute your mic.
Professor Kala, please open your mic. Okay, there you are.
Hi, good evening, colleagues. Good evening, Dr. Ramahokoba and Professor Livongo. Thank you very much for inviting me on this panel. I'm actually representing Professor Adam Mohammed, who is the clinical head of the cluster of Charlotte Mateke Johannesburg Academic Hospital. I'm a qualified pulmonologist, and one of the few that Dr. Professor Mervyn Moore has mentioned is also dual certified in critical care as well. The one thing that has not come through clearly from the previous speakers is that this third wave is behaving in terms of the COVID numbers and COVID mortality completely differently to the first two waves. So what we've seen is as the virus seems to have mutated, so has the phenotype of the disease changed. And we need to be aware of this going forward. And we need to prepare for this appropriately. So we need to draw on our colleagues internationally and find out what their experiences are, because we're lagging behind in terms of our exposure and our preparedness for this particular virus. So what we saw in the first wave, we saw a much more milder illness. We saw a significant amount of pre-viral symptomatology, or what we would call the viremic phase symptomatology. We saw a lot of loss of smell, loss of taste. But the second wave, we saw a bit more of acute illness in terms of respiratory illness. And unfortunately, that did not prepare us at all for the third wave. And what we've seen with this third wave is we've seen a delayed presentation of illness. We've seen a much more higher acuity of illness. And I'm not too sure whether that's because of complacency that has set in from our part, whether it's because of mental fatigue and physical fatigue, or whether it's because the virus has mutated. But it's something that we need to bear in mind going forward, and we need to be cognizant of this, that this disease is in flux all the time, it's changing all the time, and we need to be prepared for it, and we need to make sure that we don't take it for granted. The other issue, being a pulmonologist, that I need to bring to attention to the panel is that in my mind, the fourth wave has already arrived. And what's the fourth wave to me is the significant post-COVID lung disease, or the illnesses of the respiratory system that our patients are experiencing who have survived COVID. I think it's an underestimated proportion of patients. You know, if you look at the statistics, about 85% of all our COVID patients will remain asymptomatic, but there are 15% of patients who will develop symptomatology, and of which 5% of them will need critical care medicine. Now, within that 15% of patients, there's a significant burden of disease. And those patients are the ones that are and those are patients who, at the moment, we don't have a clear strategy about the management for those particular patients. And I think we need to be cognizant of that, and we need to understand, you know, that these patients are suffering from significant problems, psychosocial problems, psychosomatic problems, cardiovascular problems, vascular pathology, as well as primary respiratory diseases. And I think that's very important for us to bear in mind, especially when we preparing for our healthcare budgets going forward. The other issue that seems to have been neglected in our preparedness for the COVID is that of our COVID response is the lack of basic healthcare to our other patients. So COVID has been all-consuming. You know, at Charlotte Mateke Johannesburg Hospital, most of our outpatient clinics were closed. A lot of our patients had difficulty attending outpatient clinics, and in doing so, a lot of their chronic illnesses were neglected, and this posed a significant healthcare risk to these patients, as well as a significant burden on our current existing healthcare infrastructure. So we had a lot of hypertensive, diabetic patients, asthmatics, COPD patients, and patients who required more imminent and important healthcare needs, like our HIV positive patients who required ARVs, and our tuberculosis patients who needed to complete their TB care. So these are conditions that we need to be aware of. We need to factor in terms of their management going forward, and we need to be very cognizant of their burden on the illness going forward, because they are an indirect collateral damage as a result of COVID. The other issue that we need to be aware of is, you know, one of the mainstay of therapies for COVID that Prof. Moore has highlighted has been the extensive use of corticosteroids to try and placate the inflammation in the lungs. And that has created a second problem. It's created a problem where we've seen, an increase in incidence of secondary infective processes. But more importantly, we've seen an unmasking of tuberculosis. Prior to COVID, one of the biggest healthcare threats to our healthcare was tuberculosis and HIV. And I think that has taken a backseat to COVID, and we need to bring that back to the forefront. And there's a significant amount of literature being published looking at the coexistence of patients with COVID and tuberculosis, and we need to be aware of that. The other two issues that I just wanted to bring to the attention of our panelists is the emergence of diabetes. Is a diabetogenic illness, unlike any other virus that we've seen, and it poses a significant threat to metabolic illnesses. And we do have a significant burden. If we look at our chronic illnesses in South Africa, diabetes is the second most common chronic illness in South Africa. And with the combination of COVID and steroids, I think we need to be, putting this out to our patients that, all those patients who coalesce from COVID, that they need to have their sugars checked and need to make sure that they have an unmasked diabetes. And finally, I would just like to reiterate what the rest of our panelists have said, is that COVID has offered us an opportunity for us as a country to function as a community, as a healthcare community. It's something that we've never done before, but we've all developed WhatsApp groups. We are all on these significantly important WhatsApp groups where we're sharing, different therapeutic strategies, where we're sharing ideas, where we're sharing our difficulties and our gains. And it's allowing us all to draw on one another's strength and one another's knowledge in order for us to prepare and manage our patients a bit more better. And finally, I'd just like to, mention, that one of the significant problems about this third wave was the loss of Charlotte Mateke Johannesburg Academic Hospital to an unforeseen, act of God with that fire. And that has put a significant strain on the rest of the healthcare sector within the Gauteng province. And I'd like to thank all our colleagues who stepped up, who assisted all the staff members at Charlotte Mateke Johannesburg Academic Hospital for aiding us in our patient management, in our teaching, needs, for accommodating us at their hospitals. And now we just want to implore the government to try and get us back on track so that we can reopen, the flagship hospital of Gauteng so that we can start offering services
Yeah, indeed, Prof. Kala, the Charlotte Mateke fire was a huge, huge curveball, and we must commend everyone, including the nearby hospitals, the health workers themselves that had to move away from their usual point of work and all that. We really greatly appreciate that and still have to face the third wave. Thank you very much for that. And the last contribution from this section of hospital-based experience is Dr. Lehlohonolo Majake Mogoba, and she'll share with us the more private sector experience. Dr. Majake Mogoba.
Very good evening, colleagues, political leaders, all protocol observed. I would have wanted to share my presentation. However, this doesn't give me an option to do so, so I'll speak to it. I think I'm supposed to just basically communicate about my journey as a general manager within the private sector. And I think basically with the first wave, there was a lot of uncertainty. And what was good about it is we managed to actually collate data based on countries that had already been through the experience. And what I saw was really good collaboration between state and also private sector, particularly when it came to knowledge sharing and also development of various protocols from an occupational health and safety perspective, and also in terms of just labor relations and protection of the staff and users of the health establishment. And one thing that I actually experienced was the key to success in managing this pandemic, especially at that moment in time in the first wave when there was so much uncertainty, was to leave nobody behind. So all categories of staff have to be roped in, whether they belonged to yourself in the hospital group or were outsourced service providers, whether it's catering or security and so forth. I must say that based on what we saw on the news and etc., and in anticipation of what we saw in Italy and the likes of China, there was a lot of repurposing of infrastructure. But because of the very good initial response in with level 5, we actually found that we didn't need to. So a lot of us erected tents, and there were images of various hospital groups having set up in their basements, but we found that we actually didn't need to use it. But from a human resource perspective, I must say that there was a lot of confusion as well with regards to PPE and what to wear when it came to aerosol generating procedures versus general care. One thing I would also like to stress, particularly with state and also management in state, was there was so much discordance in terms of what WHO says versus what state actually said, and what we subscribe to, which is WHO recommendations in terms of PPE, that there was a lot of unhappiness between staff and management. And I think going forward, these are some of the things that we actually need to engage on as both state and also as private sector. There were definitely severe mental health issues that we faced. And also I think the challenge was you were so busy trying to catch COVID and manage COVID, and protect patients, that there was no time to really focus on the mental health issues of the staff. And I think when we look at the trends of the first and second and third wave, there really hasn't been much time to actually take a break. And that's something that we need to really expand on in terms of what we're going to do with healthcare workers and the mental health. And unfortunately, because we were so under-resourced, both in state and also private sector, a lot of staff have actually had to work far more hours than they would regularly work. We even had unfortunate, which I used to call never avenged circumstances, where staff would work at 24 hours at a time. I think one thing that we found difficult as private sector was also having to accommodate state patients when there were no beds. And this would happen at a time where, you wouldn't really know where to down refer them or refer them into a state hospital. And there was a lot of red tape in terms of engagements with, for example, the MMO on call. You would call somebody and say, I've got a state patient, we need a vent, they're on a ventilator, and they've got such clear criteria in terms of which this patient should be referred to. And I think this is something we need to look into. How do we make it easy for private sector to really take state patients to areas that would then be able to manage them further? We experienced a lot of elective surgery cut down in private sector, and that has had a tremendous impact on our doctors and also ourselves economically. But of course, we had to focus on what mattered most. At that moment in time, it's those most in need from COVID. I think what I appreciated as well was the information technology use that we did with regards to DATCOV and also reporting of the deaths and mortalities. And there were several M&Ms that were set up in which private and also state could collaborate. And of course, from a drug and medicines perspective, we had severe challenges with, a shortage of medication. And I think that's also something that I see as in the fore in terms of, how do we make sure that as a country and a continent overall, we capacitate ourselves in terms of medication so that we don't have a situation where patients have medication that they need, but we actually can't give. Second wave was definitely far better in the sense that there was a bit of an anticipation of it. We saw the increased mobility with the population because it occurred around about December time. And I just think that it wouldn't be true to actually say we didn't anticipate it. I think the unfortunate thing about it is it came at a time when so many people were now more relaxed because of mobility, and we had to recall staff. So we had staff who were already starting to take leave, but then had to go back and get back into the pattern of managing very sick, critically ill patients again. And it's difficult when you've got staff who are already on a very low base to then go back and have patients who have high acuity and really need massive attention in terms of management. One thing that I would also say is there's a lot of duplication in terms of what is expected of us as private sector to deliver when it comes to information and data. There's DEDCOF from national, there's various provincial expectations as well. And it would be good to actually see how we can centralize our communication in terms of data that is given forth so that the various provinces can also use that central database. I think that's one thing that we need to really look into. And of course, the third wave, here we are at this moment in time. Did we expect it? I think certainly we expected a third wave, but what we did not expect was a variant, especially with the Delta variant and what we've seen in what it's contributed in terms of the clinical picture of patients with COVID. I think it certainly mirrored the timing of the first wave. But, as the previous speakers have spoken, the clinical picture was far more deadlier, excuse the pun, as compared to the first. I must say that there was really good collaboration though that we've seen. And this is what I'd like to stress from somebody who's in private sector is we have to really bolster our PPP, and remove barriers that actually make it difficult for us as private and public sector to actually work together. We've seen how the vaccination program in the country has really worked very well and based on 3 principles. Single rollout plan, which is guided by a public sector, private then just basically implements. Resource optimization, where you have the uninsured utilizing private sector and the insured also using public based on where they are in locality. And I think certainly joint collaboration and transparency has also helped a lot. So this is one thing that we can actually learn from COVID, and also trying to catch up with vaccine rollout that I think can apply in terms of other waves to come, and obviously preparation for the national health insurance as well. What was a bit of a challenge now was
can you please round off, my dear? Thank you.
In conclusion, I think certainly there's COVID has really taught us that PPP collaboration it really is possible in South Africa. And I think we need to look at how we can bolster that. I think what is also key is we need to look at ways in which we can have more flexibility in terms of repurposing of beds, particularly at the peak of COVID, because we often restricted with what our licenses give us. And at times we do have resources to increase capacity of high dependency wards. And of course, sharing of staff, that's one thing we need to look into. How do we get our nurses to work in state and vice versa, based on where there's a shortage? That can only happen if there's centralized communication. And also, how do we use our private consultants to then engage with medical officers where state consultants are also stretched? And I'd leave it at there. Thank you for the opportunity.
Thank you very much, Dr. Majake Mogoba. I think what you are also indicating is that the resources are not limitless, even in the private sector, and that we have had to share the resources, the meager resources we had, also sometimes because of supply chain interruptions, as everywhere in the world. The same resources were required, especially in terms of medication and so forth. But thank you very much for your presentation as such. I think I'm told that Dr. van der Merwe has been replaced by also someone from PE. Dr. Tobias Fodo, are you here? When we were planning this dialogue, we discussed the 5 minutes allocation of time. And Professor Luvengo was very clear that 5 minutes is enough to say everything that is critical and important, because more of our colleagues wanted to share. So I think let's share the 5 minutes and try and manage it ourselves, so that we can get at least a dipstick of what happened where you were. We should also commit to penning it down, writing it, so that we can also be able to have an observatory or suppository for it, and use that indeed as an observatory. But thank you very much. This ends the first session, which was really from the hospitals, where patients who were very sick found themselves. We're going to get into the next session, where we're looking at how the public health response has been, including district health services and primary health platforms. To kick off this session, Dr. Desmond Kegakilwe, who is part of the district health services in Mafikeng Northwest. Dr. Kegakilwe, please go ahead.
Thank you. Thank you, Dr. Gwen and Prof. I think he has managed to join us. Honorable Minister and MEC and MP, member of Provincial Legislature, colleagues. let me just say that some of the challenges that have been alluded by my fellow panelists, some of them are the same, so I will not necessarily dwell into them. And I'll share the experience and maybe for correction before I start, just to say I indicated to Prof. Luvengu that I'm currently working in Khanyisa District Hospital, still in the Northwest, in Dr. RSM District. I'm working as the CEO, acting CEO and working as the clinical manager. So I had a chance to be during this era, I had a chance of experiencing challenges in the rural area as the manager and also as the clinician. So I'll give experience shortly based on that, from that perspective of rural and remote area of Northwest, that the challenges is not unique to us, but they are, of course, same challenges that are experienced in other parts of the country. So I'll just mention a few before I go to the real service delivery challenges. But from the health system, in the district health system, we obviously have our challenges, and I'll try to classify them. First of them is the infrastructure. The infrastructure is the shortage and the inadequacy thereof. Inadequacy, you find that we have an old building that we have been using, and we have been using them without necessarily no challenges. Some of them, it will be your hospital working without connection, medical gas connection that we've been using mobile. So we had to run through COVID. So it just exposed us the challenges in infrastructure. And we saw it more in previously disadvantaged areas or rural areas, because we couldn't even have alternatives, old infrastructure that we can run off. Unlike in other public sector, our counterparts in urban area, they had existing infrastructure where they could immediately renovate and use it within a period of a month or so. But in rural area, that was not the issue. We just have to squeeze ourselves within the corner and in some instances use the tent. So that is the challenges of that how we were exposed, but there were, of course, positives in mostly in rural area. The second part is the medical equipment challenges, not only the equipment per se, but also the skills on utilization of the equipment, especially in rural area, where I think Prof indicated that one of the speakers indicated about the CPAP, where we had to procure more and whatever, but we were found to be defective in terms of using that equipment in the small district hospital, where now the training thereof it was lacking. So that is the other challenge. And also we also had to improve, because we saw the challenges in stakeholders, like the former speaker Lekronolo just indicated. We had to improve our relationship within the public sector, intersectorally, and with other external stakeholders like your funeral parlor, your taxi association, where we are even seeing it, like in the Northwest, we are working with the taxi association. We are using them with to ferry the patient to the vaccination site because of the remoteness of the area. So that is the relationship that we have to force, and I think going forward that will prove to be beneficial and improve the service delivery. And of course, we also, like with the other factors like hospitality sector and mines and other industry, where different districts has to forge those kind of relationship. And then another one that we had to go to is we were also the OHS and IPC, occupational health and safety of employees, and infection prevention control, that we had to improve, and that was a chance to identify all our gaps. And very important in the state is the IT challenges. I would not dwell into, because I know that, like, for now we all the meetings have to be virtual and all that thing. But in more remote area, the challenges you find is the connectivity, lack of thereof, because of poor infrastructure in terms of connectivity. I'm aware of my 5 minutes that have just lapsed, but I'll just conclude. So connectivity, it's a challenge where we have to talk to the network service provider, and we are not necessarily winning. So also in terms of IPC, prevention of contamination, where we have to move from paperless to digital. So that is a major challenge that I think we'll have to have the session on how to improve that. And lastly, my point at the service delivery is only three things. Some of them Prof Mer has talked about. First, during the first wave, the fear from the staff and the patient, where when you are affected, I had to come home. When coming home, initially is that, am I carrying the virus to my family, to my kids? What should I do? And also all the staff members have that fear and how to challenge. So there was emotional turmoil, and eventually we went to emotional fatigue as the healthcare workers. And equally, the patient, I think, went through the same, that tension, emotional, mental health, were much challenged, where we see a lot of conflicts between, the complaint rate went high from the staff and from the patient, and there were a lot of misunderstanding. And the understanding that we deducted from that, it was there's this tension between healthcare workers and patient, and everybody was fatigued emotionally and was very fearful. And that was coupled also with the staff shortage, where we couldn't even do what we see in other departments of rotating the staff. I've seen one of the attendees asking about why the Department of Health is not rotating staff. It's not possible in some areas, especially in public sector, where we've been having a chronic shortage. And now with the increased utilization of our services and the need thereof, we cannot at all do what other department is doing. And unfortunately, we see DPSA, when they release from Honorable Minister, when they release the regulation, they will not have specification for the Department of Health, which we had as managers to some extent fight with the employees to say that, but this what are the regulations say, and they were not at all applicable in our department. So I think this was a chance, and we can, going forward, discuss and have a dialogue on how we can use this experience and challenges that we have experienced to can see also, because I see much opportunity to can implement NHI. Thank you, and my apologies for that extra 2 minutes.
Thank you very much, Dr. Kihakilo. We greatly appreciate your contribution. I'm going to ask Dr. Tobias from Livingston, and thereafter head over to Professor Luvengo to continue with the session. Are you here, Dr. Tobias?
Yes, I'm here.
Please go ahead.
Yes, I'm here. Good evening, everybody. My name is Toby Safodo. I am one of the few intensivists.
My apology, Dr. Toby Safodo.
Yes. I'm muted. Am I muted again?
No, I was apologizing. I didn't call your surname properly.
Oh, no, it's okay. It's not a very common surname. I'm one of the few intensivists in the country, and I work with Dr. Van der Merwe. She has apologized for not being able to join this evening. And I come from Livingston in the Eastern Cape, and we serve the bulk of the western part of the Eastern Cape. And from the first wave, we were actually fortunate to have a field hospital that had been opened, and we were also fortunate to have some private funding that we were able to purchase some equipment such as high flow nasal oxygen, and also make a little bit of expansions into the buildings of the ICU. However, with all that equipment, it does not help a lot when we have unfortunately had we have had lots of changes in management. We've gone through a number of CEOs in the last couple of years, and this unfortunately has led to difficulty in continuity. And all the equipment that we've had a serious issue with nursing staff, that we do not have enough nursing staff, and in terms of doctors as well, we've also been privileged in the sense that some departments have come to assist in the fight against COVID, and just to assist, I'm speaking more for the ICU. However, we've just had issues with the members of the other hospitals that other departments that were could not come to assist us at all. And I'm not going to repeat what's already been said, but I seem to share a lot of sentiments from the speakers that have spoken before. But just to also say that we've also had to, in our ICU, but I think this is something that has happened across the board in terms of using a triage system. Fortunately, the Critical Care Society has had guidelines in terms of assisting us with triage, and we've been using it. We've been using that, and the majority of our patients, I think this has also already been spoken to as well. We focused our efforts on the patients that we think will do best, and we used our resources in terms of placing those patients who are on requiring high flow, and we avoided intubations where we could, because we know that the mortality in patients who have been intubated with COVID, particularly those who already have other comorbidities, is much high. And it's already been spoken to the issue about staff fatigue, burnout. We were also not spared from those issues, and we've called in a psychologist, and we at this stage have regular sessions with our in-house psychologist, with group therapy, and some members are also going for private sessions. But there have been gains, and I think there is a lot that can still be improved on going into the fourth wave and going forward. And I think, yes, the moratorium against hiring of new staff has been lifted, so we probably could hire, but the main pressing factors is relates to nursing staff and also more doctors, and also perhaps also more leadership in terms of the other departments to to join, and if we could have every member of the team in a hospital, the departments that could also come in. I'm actually we are grateful for the departments that have come to help us, but the issue of people and the fear that comes with looking after patients with COVID, it's a global factor, and I do applaud the staff and everybody who has worked hand in hand with everybody to come to terms with this. And without further ado, I would like to thank everyone for this opportunity, and thank you. Am I still here?
Yes,
yeah,
thank you so much, Dr. Koda.
Okay, thank you very much. Well presented. You kept to time. Thank you. Can we have Dr. Mweketsi Mate?
Thank you, Prof. Let me pass on my regards and my greetings to everybody, all protocol observed. I will try and make it 5 minutes, Prof. Thank you. As a doctor in private practice, there are a few things that we were faced with in the first wave. The first one, obviously, was I was spoken to, was a fear. We had a great fear of both myself getting infected, family getting infected, patients getting infected. But there was also an issue of quite a lot of us had decreased income, especially towards towards the month end of the very first wave, where we had a going joke that at the end of the month, may the best debit order win, because all of us saw at least a 60% decrease in income, and that was a problem. There was also the issue of stigma. There was a worry that if a patient were to be found to be positive in my rooms, would that mean that people would be afraid to come consult in my rooms? And that created a problem in itself. We also had a major problem with sourcing PPE. If most of us remember that masks were going at 13.50 Rand a mask. I'm talking simple surgical masks. where currently the price is about 50 cents. So we had to have massive capital outlays to buy PPEs. An FFP2 and an N95 mask were going at 40 Rand a mask. There was a horrible shortage of not just sanitizer, but simple alcohol wipes. So all the tools that we needed in order to practice medicine in the first wave were very hard to come by and were extremely expensive. And then, of course, there's the managing of patients. So now you've got a patient you've confirmed is COVID. You think this patient needs to be hospitalized. Getting them a bed was difficult, both in private and in public. But there was a particular problem when if you had a state patient or a public patient that you needed to refer to a state hospital. When you called the state ambulances, there was an extremely long waiting time. I can tell a story of a patient that I saw at 10 o'clock on a Saturday that I had diagnosed with COVID. I put that patient on oxygen in my rooms, and that patient was only picked up at 3:45 in the afternoon. And when the ambulance arrived, thankfully, they arrived just as the time and my oxygen cylinder had run out. Now imagine if they had been there an hour later, what would I have done with the patient on oxygen? So those are experiences in the first wave. In the second waves, similar to the second wave, but there was a lot less fear. PPE availability was better, but a lot of us, and I can speak for myself, suffered from massive anxiety and burnout. In anticipation of the second wave, I decided not to close my rooms in December. So I worked throughout December with the exception of the public holidays. So come January the following year, I was completely finished. The third wave, because most of us are vaccinated, we had far less fear, far less anxiety, far less burnout. I managed to take a holiday in March, so I was a lot rested. But the biggest challenge is that bed availability is much worse now than it was before in the first two waves. Coupled with that, because there's such a poor availability of beds, we've had to treat a lot of the patients at home. And there's a significant shortage of oxygen, be it concentrators. Good luck finding one. I mean, for the past 2 weeks, it's been an absolute uphill. But to make matters worse, the type of patients that do need oxygen end up needing 5 to 6 liters of oxygen per hour. To get that amount of oxygen, you need to give them 50, at least industrial size cylinders, talking 50 kilograms upwards. And currently there's a moratorium that size cylinders can only be given to hospitals, which is great because hospitals need it. But now it means those patients that we could treat at home, we now can't. So patients then sit in casualty, waiting for oxygen, waiting for beds in the hospital to be admitted. The other big problem that I'm seeing now in my rooms is vaccine hesitancy. I've got a lot of my patients, most of which are chronic, are having hesitancy getting the vaccine. And the lack of clear messaging coming out from both the private and the public sector on the benefits of the vaccine and debunking of the myths that are out there is creating a major problem for us, because now I'm having to spend extra 10, 15 minutes explaining to each and every patient the importance of getting a vaccine and what the benefit to them is. Of course, with that, some patients are smart enough to know that before you go for the vaccine, you need to go for your pre-vaccine consultations. So I've seen an uptick in the number of patients that are coming in. So I think one of the things that I've identified as a gap in the vaccination system is that we really do need to have somebody doing vitals on all the patients that are coming for vaccinations to ensure that their numbers are correct before we vaccinate them. And finally, the biggest headache that I personally am having is this big debate on ivermectin, to use or not to use. Is it good? Is it not? And I'm spending a lot of time debunking myths, debunking issues of ivermectin with patients, some people insisting on it. I think we need clear messaging, especially from our infectious disease guys, on what it is that we say about ivermectin and get that message out to the public. This toing and froing between those who are for and those against is not helping us on the ground, because we're having difficulty in having to have, I said, an extra 10, 15 minutes debunking those myths. Prof, I think I will end it there so that I don't go over time. Thank you.
Thank you very much. You manage your time very well. And you have convinced me that it's possible to present important issues in 5 minutes. Let's carry on on the same line. From Free State, Fezile Dabi, in the Free State, representing Mr. Modiko.
Good evening, everybody. This is Dr. Toza Matkama. I am the clinical manager at Paris Hospital, but I'm also part of the surveillance and case management for Fezile Dabi. I'll do firstly protocol observed, and then for us in Fezile Dabi, I'll just share the best practices that we had Firstly, we had the teams that were for admission surveillance, which helped us to, because we had limited resources when it comes to human resources, as we are mainly rural. And secondly, when it comes to information management, we implemented that COV and Go data, which then helped us to see our admissions, case fatalities, and then also the patients that needed to be traced and discharged. And then when it comes to case fatality, because of with being mainly rural with only one regional hospital, the admission of patients was also done in the district hospitals, in the 4 district hospitals, whereby we are also given high flow machines, and then of which then some of the patients were managed at the district level. So it decreased our case fatality, as we are now sitting at about 5.5. And then for primary healthcare, the implementation of the COPC program with the help of the clinical associates, which were funded for us by DBMI, that the clinical associate were able to train our community healthcare workers when it comes to screening of patients and referrals. And then the private and public partnerships, as we have 3 private hospitals that are admitting in our district. So we also monitor with their admissions, and they are able to help us sometimes when we have shortages of beds. And then for the 3rd wave, the vaccination rollout, it was also, we had the public and private partnership, whereby the old age homes were prioritized, as that is where we had mainly our above 60 vaccinated, which helped us also to decrease our mortality. And then bulk oxygen, we have a system whereby all of on daily basis we manage, we report as district hospital our bulk oxygen, so that we don't end up losing, because we know that when patients are on high flow, they require more oxygen. And then corporate assistance for PPE, whereby we had Sasolfem and then DBS also assisting us with PPE, especially Sasolfem sponsoring our sanitizers and also providing us with PPE. And then also community involvement with our functional JOG systems, whereby other stakeholders are there. And then when it comes to our challenges, we still have challenges with the rapid test and then the turnaround time for our PCRs. We don't really have a functional quarantine site. And then as for the district hospital and primary healthcare, when we have to refer to ICU to our regional hospital, it only has 4 ICU beds. And then as for human resources, there's shortages for both doctors and nurses, as because remember that the same colleagues that were doing programs also had to do COVID, because the staff establishment remains the same. And then the aging infrastructure, yes, aging infrastructure, our hospitals and primary healthcare centers are really not, were not made to be admission site for COVID. And then lastly, the programs that are still suffering is TB, HIV, mother and child, and our mental health services. Thank you.
Thank you very much. Again, you managed the time very well. We need a written submission from Free State. Dr. Nkosi. Dr. Elijah Nkosi, is he there?
Yes, Prof. He was here and he has been given rights to talk.
Thank you. Thank you. When my face appears, I'm indicating that the time is almost close to up. Thank you.
Yeah, I think that Dr. Elijah Nkosi is. Dr. Elijah, can you just unmute your mic, please?
Would you mind if I take the next one while?
Yes, I think you can move to the next one, Prof, and then, yeah, but he is on the
Dr.
panel.
Dr. Shansi, while we're preparing for Dr. Nkosi.
It's Dr. Nancy.
Okay, I've managed to connect.
Thank you.
Hi, good evening.
Thank you very much. Yeah, thank you.
I've been a GP in private practice for 31 years now, and I'm based in Soweto in a township called Meadowlands. This is a low socioeconomic area with high employment rate and poverty levels. Few people have medical aid, as those that were born in the area who are now professionals have moved to the suburbs. And the area closer to where I am, there is a block of houses, about 6 houses. I mean, they're just sharing a wall in between. So it's actually highly concentrated houses. So the main challenge that's facing our community is overcrowding around where I am. And there's a very high unemployment rate and fewer people can afford private healthcare. Most of these people generally go to public clinics. Occasionally, they will save enough money to pay for our services. We charge a global fee. Looking at the 3 waves, I would say the 3rd wave has been quite intense and has infected far more patients than the previous 2. My experience, or generally our experiences as GP who are serving in these areas, are largely common. There are challenges that are faced by insured people. These are minimal. We have a national GP network that has helped in developing guidelines, and we share this information via WhatsApp and other media. The main challenge seems to be shortage of hospital beds when we have to send a patient for admission, and this delayed their admissions. But those who are mildly infected and asymptomatic, we are able to treat and monitor them virtually. The greatest challenge seems to be that is facing cash paying patients. When we suspect that a patient has COVID-19 and we send them to the local clinic for testing, in some instances, we find that there are no tests available. And even in instances where when they get tested, tests will come after a week or so. In the meantime, we would recommend that this patient should isolate. And in this instance, might find that in one yard, there would be more than 4 families sharing the same toilet, and 2 parents are staying with 2 kids in just one garage home, something like that. So it just becomes a challenge to ask them to isolate, in that it's not possible. It was better when there was the field hospital at Nasrec. We could send them there, those who could not isolate. Hopefully, such a facility would be available. I think also create a challenge, the challenge that we have with social media that is pushing alternate views that are non-scientific and non-medical. We've tried to convince some of our patients, but it seems that they are set in their ways. There are some of the people who have engaged who just don't believe COVID-19 exists. They refuse to wear masks. Even when they are infected, they continue to socialize and attend mass gatherings. I mean, one patient passed on who, in actual fact, having been diagnosed with COVID, is still addressed political meetings. We also have a challenge of people who are anti-vax and who are imposing their belief to their parents and grandparents. In this case, you find that a youngster who's supporting the family tells them that they shouldn't get vaccinated. They refuse to register them on the EVDS system. When they do come and we talk to these old people, they tell us that their children or grandchildren say they should not get vaccinated because these vaccines are meant to reduce the population and lead them to their death. Ivermectin proponents, that's another challenge. We have people who are pushing ivermectin and they actually think, and people who are taking it tend to think that they are immune to COVID infection. They also don't follow protocols. And lastly, the breakthrough infections. We've had quite a number of colleagues who we vaccinated with around February, March, who got ill, and some have passed on. So now the challenge is, what do we say to our patients if we know, or we have cases that we know of people who were vaccinated and have passed on? But be it as it may, I think it's something that we will continue pushing and trying to convince the patients to do accordingly. Thank you.
Thank you very much. Again, well presented, clear message. Thank you. Dr. Nancy, is it there?
Yeah.
Yes, Prof. Dr. Nancy is connected and has got panelist privileges.
Okay, let him fire. Are we winning, Siviwe?
I think, Prof, maybe let's just move on. I'll just try and communicate with him directly. We'll try to win. We aim to win.
May I ask my co-chair to carry on from here? Thank you.
Thank you very much, Prof. Dr. Nancy is struggling to find where he can unmute himself. If Dr. Siviwe, you can assist him once he's ready, we will then call on him. Thank you very much, colleagues, for sharing. We will now get into the next section where we really are focusing on the well-being of the health workers. We know that you have touched on this aspect, but this section just focuses. We've got 3 speakers who will be direct to the point and concentrate on the well-being of health workers, because indeed health workers have been truly heroes and heroines. Dr. William Malibate, who is an infection prevention control specialist at Charlotte Maxeke Johannesburg Hospital. Dr. Malibate?
Yes, good evening. I'm not sure if I'm audible enough, or can you see me?
Both, yes. Thank you very much. Please go ahead.
Good. Let me just start by giving the background of what we have done at Charlotte Maxeke when we started with this COVID-19. Colleagues, to be honest with you, that is being identified for management of COVID-19. There were 3 hospitals which was Steve Biko, Tembisa, and Charlotte Maxeke, and then of which Tembisa fell off, and then Charlotte Maxeke and Steve Biko remained. What we did by the 24th of January 2020, we had our first preparatory meeting where we invited all the stakeholders to prepare for management of COVID. Remember, by that time, we didn't know anything about COVID, but this Charlotte Maxeke has been one of the hospitals that has been identified to manage infectious diseases like the viral hemorrhagic fever cases, Congo, crimin, and chicken carriers. We were already prepared so that we are going to attack this infection aggressively. And 11th of February is when we started to have a training workshop, the IPC training workshop, as we're strengthening and reinforcing on IPC measures. Remember, I said that the approach, we have approached it as a viral hemorrhagic fever when we started. And then we trained the cluster hospital together with the clinics around and some of the hospitals that were in Gauteng. 7th March 2020 is when we started to admit the first case of COVID-19 positive patient, which was the second patient in the country. And I can tell you that it created a lot of anxiety, fear, and panic to all the staff members. So what has happened is that we established a COVID-19 committee where we sat and start to have to make sure that we put all the protocol in place and making sure that we are developing the contingency plans. And then by the time we had only 3 wards that were allocated to manage COVID-19 patients. One was the ICU, one was for PUI, and then one was the medical ward. So we really staff were panicking a lot about that because that was for the first time to manage that. Initially, we approached it aggressively, as I've already indicated. We were using triple layers PPE because of the stuff we were not feeling comfortable that to use that. And then we knew that, you know, as we move on, protocol will be changing. As we were changing, we will come back to make sure that we allay fear from our staff members. And the first patient that was admitted was managed by the nursing staff, and that some of the staff did not have any knowledge about COVID-19. They were trained, but because of knowledge, once they were having anxiety, they panicked a lot, and they were afraid and fearful of saying that they will be infected, they will be contracting infections, and then also they will end up infecting their families. During the first wave, we trained a lot of staff members. Almost 8,980 healthcare workers were trained. That we were including Cluster Hospital together with the clinics and nearby other private institutions that were around, Johannesburg, Charlotte Maxeke. And I think we all know that Charlotte Maxeke is the hospital that is in the core center of Gauteng, where everybody, the epicenter and everything, at the present moment, so that created a lot of challenge because of everybody wanted to come to be admitted in Charlotte Maxeke. So what we did is that we created a multidisciplinary committee members. We created a WhatsApp group where we were discussing, and then we had organized labor to be part of what we were discussing. Because remember, when we started, some of the staff members felt that they must get a payment for a COVID danger allowance. And there was that sort of disgruntlement of coming to play as we manage COVID-19 cases. So we ended up inviting also the organized labor to come and assist. During the second wave, the second wave, we did not have enough time to sit and plan. We were very busy because at 8 o'clock in the morning, when you come on duty, you'll be prepared, you'll be told to say, no, go and prepare and open a ward. What needs to be done is that we have to organize staff to run around to get beds from one ward and close one ward, open another one. And this poses a lot of challenges to staff members because of they have to move that around and staff to be mobilized from one area to the other. And some staff reported that this mattered to the unions because of they were feeling that they were abused somehow. So we ended up creating that a good relationship. Absenteeism of the staff also created a very bad situation because of we ended up having absenteeism where there was still a shortage, already having a shortage. Challenges that we had, firstly, was a shortage of resources. Beds were moved around repeatedly and continuously as they were high demand for admission of patients. There was no much time to given to prepare for wards as patients. Turnover was very high. Beds were taken from other departments and discipline, and there was no time to update inventory. You know, there was just a movement over the area. And that one created a challenge as to be somebody has to account where those beds are. Poor oxygen supply, sometimes we have to have a point where now we have to move the patient and this area does not have a point, then we have to move with the huge oxygen cylinders, which becomes a problem because they are heavy to be carried. PPE challenge also created a very big problem. Remember, staff now were not happy with the single layer when we start to say, colleagues, this is what you need to wear. And then introduction of the KN95 also becomes one of the big problems because the staff members, they were not happy with the KN95, feeling that they are not properly protected because it was a new mask that they've never been used by the institution. This created a feeling of not trust, a feeling of not protected, and then also creating an anxiety. We will have to, because of we getting PPE from the central depot, we end up getting low quality, insufficient or substandard PPE. This also PPE, this kind of PPE created another problem from the staff members because they were feeling that these PPE are not really of a good standard to protect them against COVID-19. Human resource and fear and anxiety. Staff has to be mobilized. Staff need to be called during the night. Staff they have to be, you know, when they don't have the time, did not have the time to rest because of every now and then, while somebody's off, will have to be called to say, come, we have to open the board, come in, assist. That created another challenge to most of the staff members. And some of them verbalized that they are having stress and anxiety and they cannot continue, and they verbalized that they are feeling depressed due to the fear that they were experiencing. And the other most fear is witnessing some of their staff members, their colleagues, being admitted with COVID, and some of them succumbing to this COVID-19. Really created a big problem. Overwhelmed by daily influx of patients, they were busy and not having time to rest due to increased workload. Those are the main challenges that were experienced by staff.
Thank you very much.
Yeah,
Thank you.
And lastly, before.
Okay.
Okay. Okay, let me just give this one the recommendations. We really recommend that we need to, the Department of Health can review COVID-19 policy, which is one of the things because we have realized that there is no standardized protocols in most of the hospitals. And then we are requesting for strengthening of IPC measures. There must be strengthening of IPC measures, especially administrative control and environmental control. Decentralizing of PPE. Remember that we're getting our PPE from a centralized depot. They must be decentralized. Reinforce and strengthening training, donning and doping. That must be done across by all the healthcare facilities and the hospital nearby. The most important area that I want to stress is infrastructural compliance to IPC. Most of our hospitals are not compliant to IPC in management of COVID-19. Thank you.
Thank you very much, Dr. Malibate. Can we have a young doctor's experience from Dr. Sivue Miller? Please go ahead, Dr. Miller.
Yes, thank you so much, Dr. Green, and all protocol observed in, observing time and how Prof. and Mugwen just would like us to be. So I'm Dr. Sivue Miller. I am a member of Medical Women's Association, and also I am a young doctor, having qualified in 2015. So the biggest challenges that have been on the ground
with young doctors, be it your interns or your ComServes or recently qualified medical officers, is that we've been working in very horrible conditions. I'll speak especially after the burning down of Charlotte Maxeke that has really put pressure on Gauteng hospitals, which I mainly work in. And it has been horrible to a point that there have been calls where we had to do resuscitations on the floor. When I mean a whole resus, I mean chest compressions and intubating on the ground. I have never done that in my life, and it's the most horrid experience, especially when patients are around you and looking, because this is a situation where there are no beds, there are no stretchers, there are no wheelchairs. You can't get a diversion for the hospital because the MMO, everybody else is on divert. So those are the real life situations. And I think the harm and the psychological impact is something that will come only later on. And unfortunately, this time has been so hectic, especially for the interns and ComServes, is that it's a different way of practicing medicine. Any person that has been in this career for long would say that this is unprecedented times. But yet, how do we support these junior doctors? There's not been support on the ground, and especially either be from senior doctors or even from the CEOs or just management. It's also been a time where we've been losing a lot of people. We've been losing a lot of healthcare workers, and people have been losing a lot of personal members or people that they are close to, and we've spoken a lot about that. We have not discussed also a platform, and this is something about medicine that has been going on for some time, where you are expected just after a resus, that failed resus, you're supposed to see the next patient because the line keeps on moving. But that has had a great negative social impact and a physical impact and emotional and psychological impact on young doctors. And I speak specifically for me, there was a time I had to take a break from clinical medicine to go and seek help and be able to pay for a clinical psychologist. Also, I feel that there could be more improvement on EAP programs. So for those people that work, especially the doctors that work for the Department of Health, like internship and community service, which is compulsory for you to work for the department for those 3 years, the EAP program has totally failed the young doctors. There is no advertisement of it. There is no proactivity from their side. And to a point where many people don't even know that there's an option for that. And also, anybody who wants to take on services of a clinical psychologist, those sessions go for about 1,000, 1,500, maybe max per hour. Some medical aids don't cover you, and also clinical psychologists have been quite flooded. Yes, there have been platforms that have been offering for free. I just forgot the name of the session now, but I think they give healthcare workers up to 2 or 3 sessions. But from the department side, I think it's something that we can take home, that that we strengthen from DPSA side, that they strengthen the EAP programs that are currently there. And I think the biggest challenge and the biggest thing that I would like to represent to young doctors and say to all the stakeholders that are here and listening is that they need the support. They need to know that they're not alone. They need to know that everybody's feeling the way that we are feeling, that we are down, that we are tired, that we don't want to do this anymore. A lot of my colleagues are leaving medicine. Some people are going to corporate. Some people are just leaving medicine totally and doing different stuff. And the impact of COVID-19 has also been quite bad on some of our colleagues. I know of a colleague who has had memory loss and she's had to leave medicine because of that. So also, how do we then try and re-equip, this will come very nicely with your EAP services or OT services, on how do we upscale or enable these doctors to function in better disciplines, or maybe in other disciplines than the ones they had previously liked or maybe want to follow, and because of the side effects or because of the complications that I've got from COVID or anything else. And I think just another one, yes, we're working with little equipment, we're working with less resources, and we're all tired. But I think, and I beg that the people that are in power should acknowledge and at least give a nod where things are done right. Most of the times, especially as junior doctors, you feel that you're always under the microscope. Everybody's looking at you and just like, but you know what? Why didn't you do this blood gas? This is a venous blood gas instead of arterial. But yet the moment you do the right stuff, there's never acknowledgement. It's sort of a thing that you are expected to do it. So I really would applaud the powers and the people that we start also giving positive reinforcement to the young doctors. Thank you. I'm done, Dr. Gwet. My time is up. Hello.
Hello.
Yes, yes, yes.
Can you hear me?
Yes, we can hear you, Dr. Nancy. You can go on.
Sure. It's been hectic. I would like to greet everybody and say protocols observed. I'm a bit harassed. I'm going to be very short. The point that I wanted to make is, for me, doctors, including GPs, should have been drafted, and I'm using drafted deliberately. This has been a very serious emergency. We knew there was a monster that's eating people, and every soul did need to be drafted in. The one major weakness that we had, there was no information. We didn't have these webinars, and it was a nightmare to get information. It's not in any textbook. And unfortunately, even when attempts are made to have webinars, they are held at times when many of us are at work. Last year, I was running a GP practice in Mamelodi, as well as working full-time in a clinic in Hammanskraal. And unfortunately, when you're at the, you cannot afford disturbance. You have to work. You've got to see those patients. The second thing, it said it was a nightmare. Information availability was a problem, especially at a time when you get people who claim to be specialists. They say it is G5, I forget the name now, this thing that we use in cell phones, you know, that increases speed.
5G.
5G, yes. A lot of people who claim to be specialists talking nonsense like that when their information is not full. And unfortunately, we did not have enough support by way of information to make sure that you can dismiss these things. And unfortunately, information came very slowly. And then when it comes to COVID, we did not have enough information. Again, it took too long to come in. There was a lot of fear of death. There was a monster that's devouring people everywhere, and it's going to devour everyone. And patients, unfortunately, yes, we did tell them to stay away from the hospitals, stay away from the clinics. And what happened? They stopped coming for their hypertension, HIV, and all these other forms of treatment. It's, in other words, our information was not good enough. And it is these Zooms of this world that make a hell of a difference. Give the patients information. For those who are in employment, we were able to write prescriptions for them. But unfortunately, the information was not standardized. There were no protocols. We did not have, you had different pieces of information from many sources. We desperately, what I also observed is that when you treated a patient early, they did not die. The only problem is, when do you draw the line and say, this is just flu, or this is COVID? And my attitude was, I don't mind erring on the side of saving the patient. But unfortunately, in the clinic, what is done? Panado and vitamin B-co, sometimes oral rehydration sachets. And then the patient is told to go and self-isolate at home and come back when they are sick. And very often they come back when they cannot breathe. These are things that have been happening. And my attitude is that, why can't we have protocols? We had HIV, it was a nightmare. It was very expensive to treat. When the protocols came, they simplified the whole thing. And this time, there was this gap, a very big gap. It's that we could have done something about. Yes, I do understand it was going to cost quite a bit in terms of paying for medication by government, but we could have saved a lot of lives. We could have reduced the flow, the jams, traffic jams in the government hospitals. When you treat a patient, you save that life. I didn't lose a single one, and I did not use ivermectin. And I did not use hydroxychloroquine. I did not use, the only thing I've used is the thing that we use to treat gout. But we've got these bits of information. We could use them. The impact on the staff, yes, I'm not going to touch on that. It's been touched already. The other problem is the NHLS resourcing. They run out of test kits. We should not have that. When you take a specimen and you send, it takes 4 to 5 days to be tested. No. And yet, when it comes back negative. And yet we had all the signs that this patient definitely, this is COVID. These are the problems we're getting on the ground. We shouldn't. I hope I'm not taking too long. Just the last thing I wanted to mention. It is the use of TV. Information is everything. The use of TV and radio in vernac, in Zulu, in Setswana, in vernacular. We've got too many soapies. Why can't we slot in these educational things? Slot in COVID, there's a crisis. It's said that is the little bit I wanted to mention. I've got other things. Many of them have been touched already. I think I'm going to leave it here. Thank you. Thank you.
Thank you very much, Dr. Nancy. Please do forward your written reflections as well. And can I also ask those that are especially panelists and specialists to go into the Q&A section. There are colleagues that are asking questions in terms of the day-to-day clinical cases that they see. And if we could be of assistance, I think that would help. But we will also deposit the email address, especially of Professor Luvengo, who will then be able to manage the clinical questions in particular that are arising. Thank you very much. Dr. Maggie Mujapilu. Dr. Mujapilu has really been at the forefront of supporting health workers, especially including the families of health workers. And is she still here?
Yes, I'm here, Gwen.
Okay.
Yeah.
Please, go ahead and address us. We also aware that you are in the recuperation phase after having gone through a very, tough ordeal, like many other colleagues. And please do share with us, and we are grateful that you are able to come on this platform.
Thank you, Gwen. Thank you, Professor. Colleagues and all protocol observed. As the COVID descended on our shore some months ago, never in our history have we lost so many of our colleagues, healthcare workers. And when I say healthcare workers, I've just spent 34 days, fought a fiercest fight for, with COVID. And the powers that be said, there's work to be done. Indeed, there is work to be done with regards to healthcare workers. As it descended, and a pain that slashed the heart when I saw one of the doctors that have served the community for over 3 decades and being buried alone in remote Eastern Cape. And that was at the first, the first part of the, when the restrictions were high. It pained that this hero, the doctor who has served the community so much. Little did I know that in the coming weeks, that was COVID-1, we'll have a lot of them passing on. It was against that background that Professor of Limpopo talk about selfless, resilient tenacity. That's how they described healthcare workers. And so what is next? We had to honor them. We had to honor the colleagues who have fallen fighting a good fight, like soldiers declaring, soldiers who are fighting an undeclared war armed with PPEs and masks and our visors. They went to the front line. It couldn't be a day as usual. We honor them with a roll of honor and an image memorial. And I'm pleased to say that we launched this and it was unveiled by the World Health Organization Chief, Dr. Matshidiso Moeti. In collaboration with Mwasa, we did this. And I'm glad to say that today is a big foundation with ambassadors from all over the provinces. It's a nationwide movement. And it is a legacy that we should honor ourselves for the work that we do, because I think after having been in ICU, in high care, people don't understand exactly how, how we are impacted by this and our needs. And coming to our needs as well, I'm saying families, we should not forget, we have been in touch with families. If you are, some of the messages are heartbreaking. Some of the families, we talk about breadwinners. When we talk about breadwinners, a young doctor, Dr. Poswa, because we are all over now, a young doctor, Dr. Poswa, with 2 young kids, with elderly parents. What is going to happen to the 2 young children? The Dr. Poswa, who was working in a COVID ward in the remote areas of Eastern Cape with elderly parents, lost her life, and is one of the heroes that we have memorialized. What is going to happen to to those children? It is our responsibility, I think, that we should come up with a plan. And I will mention the plan quickly. And the families, we give them duopax to thank them for sharing their loved one with us. Duopax is in a form of a hero's legacy candle of light, that their loved one's light will remain with us, and a certificate of honor from the healthcare fraternity to show that the families are not forgotten in this avalanche. And of course, we talk about the needs of healthcare workers. Issues like safety, PPE, water, and so on, they have been elaborated a lot. I'm not going to go further because some of I remember when we were burying one sister at Tintswalo, they lamented that in the speech, one of the matrons, they said the PPE came, but it was too late. That was, I think, one of the doctors in Mpumalanga. So I'm saying that this should not be a talk shop. When we talk about issues like this, we have to be solution orientated and to say what could have been done better. I would say the PPE caught up in a surprise with COVID-1, and it's one of the issues that the healthcare workers needs, of course. I would not go further without mentioning the mental health. It has been mentioned again and again and again. My issue is that the COVID fatigue, compassion fatigue, I don't mention the anxiety. Here in this platform, we have got our colleagues who took COVID home, our colleagues who gave their partners COVID and they died. We know them. We've got quite a number of them. We've got colleagues who gave their sisters, mothers COVID and they died. The anxiety, the depression, etc. My take is that everybody's talking about it. It has been zoomed many times, and the fragmented operation or system that we're working on, it cannot continue as usual, because somebody is doing something somewhere. The private sector or the public sector, we've got this fragmented system. So I think we have to be solution orientated. And in this case, for instance, with mental health, we look at digital platforms like the Pocket Couch, where they try to match the therapists and the patients to work with them, because we know that healthcare workers will not walk to that particular section. And lastly, I would like to emphasize that many of our healthcare workers died waiting to be attended. In Petersburg, we had a doctor who was in an ambulance. He couldn't be admitted in one of the hospitals and had to be taken to a public hospital. The public hospital could not take the doctor. So it is our aim that no healthcare worker should die in an ambulance. Each hospitals, whether private or public, we should have, especially during pandemics, we should have those suites that accommodate at least a healthcare worker. After having serviced the country with selflessness and resilience, you die in an ambulance. I was in an ambulance and I refused to wait for 2 hours. I said I would get into the hospital, and fortunately, I managed to get in. But I know when we talk to families and our colleagues elsewhere, Beggarsford, and you mentioned them, we've got a list of them who died, who could not be attended. I would say that has to end. I would like to end up and saying that I had the opportunity of interviewing a lot of healthcare workers when I became better in a COVID ward. And we should know that we have launched a healthcare heroes legacy fund. Let us know that there are healthcare workers who are taking home 1.4, who are taking home 4.3, and this fund, I'm saying it's specifically for scholarships for healthcare workers, because I think we have done, healthcare workers are doing and have done so much with little recognition from the citizens of this country. I thank you.
You are muted.
Oh, sorry. I was saying thank you very much, Dr. Megimujapilo. Some of the programs that you have mentioned should be profiled, and like we have a solidarity fund, we should have also a solidarity platform, so that it's not health workers doing it for themselves. As you say, the country should be doing it to support health workers. I'm just thinking that when police die in the front line of service and the soldiers, there are, honorable services that are performed to honor them, and so should it be with health workers. But thank you very much for your contribution. We're now getting into, we're really running out of time, getting into the section where we want to take Umpago, what we have experienced as we forge ahead, hopefully not into a fourth wave, but should it come, what are the 2-3 things that we must do? I'll ask Professor Mayapi, Head of Virology Department, University of Pretoria, those 2-3 things that absolutely we need to take ahead with us as we move out of the third wave. Prof.
Thank you, Dr. Ramokgopa. Good evening, colleagues, and all protocols observed. I must say that we've really had a nasty surprise with the third wave. A lot of us, including me, didn't think that we'll be hit this hard, especially here in the Gauteng province, by the third wave. After the first and the second waves, I thought, and a number of people actually have thought that a lot of people in different provinces have had good immunity from the first and second waves, and we thought that the third wave would be less severe or milder than what it has been. So going forward, what is it that we can do to prevent the fourth wave or to actually make it milder? I will briefly touch on 3 things that we can look at. And the first one is our vaccination program, and then I'll briefly touch on our surveillance program and on the non-pharmacological measures that we've been using. So starting with the vaccination program, our vaccination program started at a snail's pace, and we all know why. Earlier on, we had limited access to the vaccines that we are using, but we are now at a much better situation where we seem to have better access to both J&J and the Pfizer vaccine. So far, we have vaccinated about 10% of our population, and a lot of those are actually partially vaccinated because they've only received the first dose of the Pfizer vaccine. And we also talk of having other vaccines approved for use in our setting. That is a promising situation. So we all know that we are aiming for about 70% of our population to be vaccinated, so as to achieve herd immunity, where it's difficult for the infections to be spread in our communities. So what do we know about the effectiveness of the vaccines we have for now? Data from developed world, where there's better access to these vaccines, has shown that in areas that have higher vaccine coverage, that have achieved herd immunity, there is very low number of infections seen in those areas. So in our setting, it's less likely that we'll appreciate the impact of COVID-19 vaccination, as it's less likely that we will achieve the 70% population immunity in 3 months' time or even in 6 months' time. So it's less likely that the vaccines we have will prevent us into getting into a fourth wave. So we need to scale up our vaccination. We are currently looking at a target of 300,000 people to vaccinate a day. That is quite low. We actually need to revise that and have a higher target if we are to scale up our vaccination and achieve a better coverage in a short space of time. I've highlighted about the vaccine effectiveness in other parts of the world with better access to the vaccines. What about the vaccine effectiveness in South Africa? We have very good data for the J&J vaccine, which has been used for a bit longer compared to the Pfizer vaccine. The data that we have actually shows that the J&J vaccine is more than 90% effective in preventing moderate to severe disease and close to 100% in preventing COVID-related deaths. So we really need to scale up vaccination because there is clear benefits to doing so. Now, I'm going to touch on the next tool that we have for preventing the next wave. that is the surveillance program. We have a very good surveillance program in South Africa. We are regularly updated by NICD with regard to the COVID-19 infections. After the second wave, we were updated about the COVID-19 activities in all the different provinces of South Africa. Very early on, when not the whole of the province had high activity in terms of the number of infections detected. NICD sent out signals. We did not respond on time. I think our health department only responded about 6 to 8 weeks after those the signals were sent out by NICD that all the provinces are experiencing increased number of infections. So going forward, we need to pay attention to our the information that is provided through the surveillance programs and act on time. The other thing that the surveillance programs inform us about is the emergence of the variants of concerns in our setting. We've had a difficult situation with the third wave, especially here in Gauteng, where we only got to know very late that the third wave was actually driven by a new variant, which is the Delta variant. So we need to strengthen our surveillance system. The surveillance system that looks at, that characterizes the SARS-CoV-2 infections in our setting is lagging behind by about 2 to 4 weeks. Hence, we learned very late that the third wave was driven by the Delta variant. So we need to strengthen that surveillance system. And in between the waves, we need to strengthen the labs and hospital capacity to deal with the next wave. I've had a number of people here complaining about the service provided by NHLS, and it's quite disappointing to hear such complaints. We should not be hearing that by now. NHLS has actually improved its services after the first and the second wave. And we also now have access to rapid testing. People who experience long turnaround times with PCRs should actually contact their nearest NHLS labs and ask for the rapid tests. Now, the last thing that I'm going to touch on is we should not get tired of enforcing on the non-pharmacological measures that have actually helped us to deal with COVID-19 over time. And in between the waves, we should look at all these programs that we have at our disposal that can help us sustain the fight against COVID-19. And thank you, Chair.
Thank you very much. I thought you would say, no, don't worry, the fourth wave will never happen. But yes, if we don't scale up, it's likely to catch up on us. And I think as the data has it, the infections even amongst health workers have really gone down, including deaths, morbidity and mortality has gone down because of the vaccination program in prioritizing health workers. So yes, we need to scale up. I'm going to ask that we have Professor Steve Mui. God forbid you have the fourth wave. Should it land on us, or what can we do to limit the impact?
Thank you very much, Madam Chair. Thank you very much as well to the co-chair, Prof. Luvengo, and all protocol observed. I hope I can be heard very clearly.
Very clearly, thank you.
Thank you very much. I think when we're looking into the way into the future, I think there's just a couple of issues that I wanted to raise. One thing for sure is that I think we are going to face another wave. One thing for sure is that the virus is going to be smarter and it will continue in one way or the other to outsmart us until such time that our technology catches up. Just from one of the issues that we need to make sure that we don't lose is the fact that the lessons that we've learned in the past, can we not go back? Whether we're talking about issues around how to make sure that patients are isolated, and what we've discovered over the period of time is that if we don't control the inter-hospital infections and reinfections, we expose our healthcare workers into a significant vulnerable state. So whatever we've learned in the past, be it isolating patients, be it protocols that we've learned, can we actually improve and make sure that we go to the next level and not regress from what we have said? We are aware that it's going to be very important not to let down the mental support for the group, and that has been said here a number of times. My biggest concern is that, again, the fatigue is something that we are ignoring. The support to our younger healthcare workers is not adequate, and we need to upscale that so that we can have a strong and an effective healthcare worker system that can continue to support and work on the way forward. I just want to say that in every disaster, there's something that you learn. And for me, from a trauma perspective, what we've learned is that trauma is a preventable disease. And one of the issues that we need to look into the future that we've learned in the past is that we must make sure that we have a way of controlling and reducing our emergency departments in peak times so that we can be able to have an effective work. And I think the strong leadership that has been shown in this direction to control movement and alcohol is something that we should continue. But what we are lacking in between is that as much as we've gone a lot in terms of advertising, in terms of sharing the information around the effects of COVID, if we can utilize some of those lessons on advertising and informing the colleagues to see how we can change the behavior. Because what seems to happen is that as soon as the restrictions are moved, we are back to making up for all the time that we have not been able to have all of those restrictions on our lives. So my hope is that as we are planning forward, as we are trying to unlock, can we make sure that we open up and we use the very same resources that we use for COVID to make sure that we can unlock some of the trauma and the effect on trauma moving forward. We are vulnerable and will always be vulnerable, and it's important to protect our healthcare workers even more in the future. I think I'll leave it at that in the interest of time. Madam Chair, thank you very much, Dr. Ramoko.
Thank you. Thank you very much, Prof. Moeng. Dr. Confidence Moloko, General Practitioner in Ekurhuleni. Your reflections on moving ahead with the knowledge, the experience, how do we get into the future?
Good evening, program directors, Dr. Gwen and Tate Prof. Luengo. Good evening, Honorable Minister of COPTA, Nkosazana Dlamini Zuma, MECs, colleagues, and all protocol observed. Just in short, I'm a medical practitioner in Germiston, and I'm an activist that is involved in policy making, monitoring, and evaluation space as the coordinator of the ANC NEC Subcommittee on Education, Health, Science, and Technology. What I'm going to be saying here does not represent that anybody. I'm a former special advisor to the Minister of Health and the former head of Department of Health and Social Services in Mpumalanga. I've seen quite a considerable number of patients since March 2020. And I'm proud to state that the hospital where Prof normally works, that is Bethakawa, in Germiston, did quite a good job in supporting the practices and also the communities around Germiston and beyond. Let me just share with you the most scary experience that I had last week. It reflects the despondency that Prof talked about, where people are feeling like giving up because there is no support from above, especially our hardworking professionals and other health workers that feel that they are not being supported. I had a 31-year-old female who is diabetic and who came to my practice looking for care. She had in her hand results from the laboratory that indicated that she was COVID-19 PCR positive. I took the necessary precautions, took a good history from her, examined her. She was very ill, pyrexial and dehydrated, and had a bronchial breathing in the lower lobe of the left lung. I made a diagnosis of COVID-19, pneumonia, and diabetes with dehydration. I referred her to Bethakloa, and they saw that she was serious enough to be referred to Chris Hani Baragwanath Hospital, which unfortunately turned her home without any TTO because there were no beds and the pharmacy was closed. Luckily enough, the young girl is still alive. She's recovering well. Even if she had been sent home to infect members of her family and died. She had a TTO the following day. She had an antibiotic treatment the night when she came back without any medication. But what you see here is that even when this has happened, there are no tracing teams that has ever visited the family. In many instances, the systems are absent, and that is the norm. As we have the theme today of this meeting, that it's South African health professionals in dialogue during COVID-19 global pandemic, I focus on the sub-theme that is preparedness for the future, including a possible fourth wave of COVID-19. I strongly believe that the fourth upsurge of infection is preventable, especially if we go back to basics and also are prepared to learn from other countries that have succeeded in containing their local epidemics, such as China and Vietnam. We must be broad-minded enough to be prepared to learn even from those countries and not only to learn from the USA. If I remember the meeting that we had on the 5th of February 2020 with the ambassador of China, we could predict that there's going to be a carnage in the USA and many countries like Russia, because when they removed most of the people from China, they decided to ignore most of the basics of public health. I would plead, and I do have a slide presentation that I will send to the organizers. It does have a picture that is pleading for a systems approach to COVID-19, which is the journey from where we are to the beacon of the furthest hill, which is a place where we can say that we have been able to win the COVID war. Just as a reminder, in a very simplified way, of the genesis and evolution of COVID-19 in South Africa. SARS-CoV-2 was imported into the country by holidaymakers. The first surge of infection, all the surges or the waves, as we prefer to call them, were preventable. The first surge of the infection was an escape from the source and failure to prevent community spread into Khayelitsha and Mitchell's Plain. It spread from those areas to the Eastern Cape and to the rest of the country because of poor tracking of spread. And in Gauteng, we ended up having a focus of infection. The second surge of infections on the wave started at the Tin Roof nightclub in Claremont, Cape Town on the 4th of October. And it spread to East London, Fort Hare, Nelson Mandela Metropolitan Municipality, and the rest of the country. The third surge of the infection, which is what we are dealing with now, when everybody shouted and said, please close the borders, they were not closed. And this is a failure to implement, this way is an indication of failure to implement international control measures. That resulted with imported cases from India. And that is the reason why we are talking about the Delta strain. It is failure to prevent community spread thereafter that led to all the provinces being affected by this strain that came from India. The worst provinces that are affected is Gauteng and Western Cape, if we look at the incidence and the prevalence of the disease. Now, one can summarize it and say that the current COVID-19 upset is a demonstration of failure by the medical profession and scientists to lead the country in its implementation of fundamentals of public health. It is also a demonstration of the failure by the medical profession to demonstrate its mastery of basics of control of communicable diseases. On the preparedness for the future, we are currently being bombarded with messages from outside the health profession about the fourth wave that is inevitable and adults that must be immunized. And also we are being, what can we do now? The first thing is that we should be asking ourselves important questions. Do we understand the problem? Is the strategy correct? Are the tactics appropriate? Are the resources well determined and provided to those in need? And we must then be able to table the recommendations that are immediate, midterm, and long-term. So in the immediate, we must remember that the 2021 priority one is to win the war against COVID. We must not give up. We must accept that every deadly disease which has social and economic implications, the buck stops with the medical professionals. We must take difficult steps by going back to basics, which is to stop all identified infections and minimize death. We must stick to ordinary medical terminology instead of the new terminology that has been put. In the future, let us build now on the existing strength of the public and the private health sector. For example, strengthen our capacity in existing clinics, hospitals, instead of pumping resources into field hospitals, except in exceptional cases. We have to maintain good systems or put in place systems, processes and procedures that will not only result in the defeat of COVID-19 now, but will ensure that it prepares us to be epidemic ready against all the diseases. We must integrate COVID-19 and all other deadly diseases into infectious diseases directories. We must avoid creating new science. That is, for example, talking about the purpose of vaccines as reduction of hospitalization and deaths, instead of saying that the vaccines are there to stimulate immunity and in healthy people. And also, we have got to continue with the primary healthcare approach, strict observance of the fundamental of public health, integration of PHC approach with the district development model. And we must also highlight the importance of vaccination as being very important, and that it must be carried out within the proven approaches that are based on proven scientific evidence.
Thank you, Dr. Moluko.
Thank you very much, Megwen. I will end there.
Thank you. Thank you very much for really extensive and deep preparation and thought put into your presentation. We trust that you will also share the written text with us to analyze and indeed to ensure that we have some responsiveness or discussion around some of the challenges that you have posed. Professor Mdladla, Nathi Mdladla, Head of Critical Care in SMU. I share a platform with you, although I don't on social media, although I don't really contribute much, but I find your contributions very stimulating, very inspiring, and also very helpful in most cases. Are you still with us? I see I've lost a number of participants, and we have also inconvenienced the various leadership that we have here. Our expectation is more for them to listen, and we're really, really honored that they have stayed through. Prof. Mdladla?
Yes, I'm still here.
Okay, please go ahead.
Thanks, Chair, and good evening to everybody who stayed on the call. I was not sure actually if I was still going to speak. And I just need to touch on a few things on just reflecting on the current or the expected wave that is to come. I'm trying to, is my shared screen coming up?
Very visible, thank you.
Okay, thanks. So I'm not going to touch a lot on the first two waves as such, because I think I've actually covered that in many other talks before, what we've learned from those two waves and what informed what we did in the current third wave. Just my personal reflections is that as we've gone through the COVID pandemic, is that we've had various approaches in terms of what we do and we were trying to do. And I think the most important thing is that obviously we needed to have a goal. And the goal has shifted obviously over time. At the beginning with fears that we had of the impending wave and doom, with the possibility of overwhelmed systems, which has happened on 3 waves now. The focus mainly on trying to suppress the waves, which unfortunately it seems like we've actually failed to do on subsequent occasions for various reasons, and some of it really out of our control. Now, the question is, what really have we been trying to target? Are we trying to target avoiding death or limiting death? Are we trying to end the pandemic? Or are we going to try and find a way of actually living with the pandemic going forward and finding ways on managing it so that at least life continues in one form or another? Because with every strategy that we embark on, unfortunately, there's a compromise to be made. So one side is going to be life, one side is going to be livelihood, and in between that is going to be the psychological impacts that everybody has touched on for both patients and the caregivers themselves. So in terms of how we approach this, then it actually becomes crucial that we have this set goal that we're actually targeting and how we're going to go about it with the sacrifices that one actually is going to have to expect on both sides. Vaccines have come. This is actually a slide I made a long time ago when before we actually started receiving vaccines, and just reflecting on what challenges we're going to have with vaccines. And I think we'll all agree that these challenges have actually manifested already. The slow scale coming up, although we started moving a bit quicker now. The affordability at the beginning, but the government has obviously done a great job to actually procure some of the vaccines. The issues with obviously accessibility of this to everybody in the rural areas, in the far-flung areas, and the pressure from the mutations, which at this stage when I actually wrote this had not even happened, but actually it was to be expected that mutations were going to come, how that was going to impact the vaccines, and how that was going to impact our rollout. So really what I'm pushing towards with all this messaging is that in managing the pandemic, and I've heard a lot of people who've spoken before me, especially my fellow colleagues in critical care, touching on the issue of how this third wave has been for them, and many other people actually in the private sector, either as GPs and so on, touching on how the third wave has been for them. And this is just actually a caption of our third wave at Dr. George Mukari. And as you can see in the blue line, that's actually how aggressive the third wave has been, surpassing the second wave at about day 62, 63. And as of today, we had 702 patients go through our wards as new admissions in the third stage. And what we had done earlier on in preparation with this is that we always have a trigger for when we call a surge. That's why I can actually have days here of when the surge actually started. And then we actually then monitor the situation. But the reason why this actually come about, that we could actually handle such a big load. And for me, as I'm hearing people saying how bad the third wave has been, for us actually it was a second wave. We had a hectic second wave. And I've seen way too many deaths than anybody I think should actually see. And I think one of the junior doctors touched on it a bit earlier, and this is exactly how I felt when we were dealing with our second wave. 26% mortality with a lot of young patients that actually were losing in this particular wave, which lasted about 105 days with a total of 610 patients. And as I said, this third wave has been much more aggressive. But for us, actually, although we're seeing a lot more patients, we've actually been getting more success. So now there is obviously sensitivities about sharing what gives you success because of disagreement and so on between peaks. But the realization that we made in the second wave was, first of all, to wait until people were too sick to be treated in hospital. was really a tail end with very limited results to be gained from that. And we started chatting mainly to GPs, trying to understand how to manage the condition much earlier on, especially in that patient setting. And that informed what we then also did in the inpatient setting. And what I can say from our side is that actually we've done, I've actually been much more comfortable managing this wave. I have had less stress levels. We've hardly resuscitated people because of sudden crashes in the units and so on and so forth. Something changed by a single drug. And although, like I said, people feel uncomfortable actually talking about it. And I just wanted to show here how we've gone about that particular aspect. There's been changes within the hospital itself in terms of use because of certain impacts, especially when the National Essential Medicines List guideline came out about the use of the medication, and then some of the colleagues were uncomfortable using it, which actually negatively impacted on the patient outcomes. And the reason I actually bring this up is because I think as taught by or declared in the Hippocratic Oath, if you know a treatment, is one of actually the tenets of the Hippocratic Oath. It says you must actually share what you know works with colleagues so that they can use it to save as many patients as they can. When we disagree, we should disagree probably then with respect, which is also one of the Hippocratic Oaths, with bearing in mind that at the center of whatever that we do is the patient. And if we can prove that we actually save somebody's life with an intervention, doesn't matter what it is. Dr. Nyazi touched on this a bit earlier on, and he says he's never used a particular medication, which is actually fine. And I would like to learn from him what he's using so that I can actually then do the similar thing where I don't lose patients with whatever intervention that he's using. So learn colleagues with a central point of patient treatment should actually be the target. And we've seen a significant decline actually in mortality in this wave. At about 44 days of our third wave, we're sitting at about 11% until this report came out. And then our colleagues pulled out from early prescription of the medication, which then saw a jump in our mortalities. The subsequent increases in mortalities has actually been up by sort of a mixture of the difference in opinion in actually prescription, plus the challenges with nursing cover as well, or personnel availability. But still, as we continue actually using the intervention, we're actually seeing still at least a below a 10% decrease in mortality from 26% that we had to about 16% at this particular juncture of the pandemic. Dr. Nyazi also touched about this, and actually something that I've gotten involved in not willingly, but actually dragged into by patients, and that is outpatient treatment. It is outpatient treatment with anything. To send people at home, to say, go home, come back when you only blue and you can't breathe, for something that's potentially going to be treatable, is actually been a wrong approach that we've actually used. And I think going forward, what we need to actually do as a nation and what we need to do as a profession is to actually involve as many people as we can in actually managing the condition, especially in the outpatient setting. And the role of GPs, I think, has been grossly underplayed. Dr. Nyazi touched on the training and teaching of people. It is said that up to now, we do not have a national protocol on managing COVID-19 out of hospital that we actually distribute to doctors that actually see these patients outside. People are doing various things. There'll be those who actually sort of use our protocols for managing COVID-19. The other people are using different protocols, but it would be ideal to actually have not necessarily a unified protocol, but different options that colleagues can use that they are comfortable with, and then share results of what's actually working and not working. I've treated a lot of patients in the outpatient setting, although I'm not a GP, and we've also seen the results. And Nyazi said he's seen good results with a protocol that only involves colchicine and not the other agents. And as a practicing physician, whatever that works should be supported, and as long as proven to actually work. And when people understand what they're using, they should actually then share with other people what they're going to be using. I'm not going to touch much on vaccine that's been covered by many people. And from the nursing side, really, I think for us in the hospital setting, one of the biggest challenges, and I think it's going to be a national challenge going forward, has been the availability of the right numbers of nurses and the right skills of nurses, especially in managing something as serious as this pandemic. And I think we're going to have to seriously invest in the training, the upskilling, and actually probably getting and employing more nurses, but at least focusing on ensuring what minimum skills they need to actually have for us to be able to face whatever next pandemic that might actually come our way. So in conclusion, from my side, it's we need to change and get back to focusing on what goals we actually need. And I think right now, especially faced with the third wave, we need to limit mortalities. How we limit mortalities is going to be a strategy that involves both focused outpatient treatment and early treatment of COVID-19 with inpatient management, where we're not just palliating patients, but we're actually really treating patients. I feel like certain or most institutions at the moment, both private and state sector, with the limited therapies that we're using, people are actually palliating patients, and the high mortalities that people are talking about. We haven't been overwhelmed at our hospital. We have a 280 bed capacity for COVID-19. The maximum that we've had has been in this particular wave, which has been a hectic wave, has been about 220, I think, cases that actually admitted on a single day. And with those numbers, we still haven't felt significantly overwhelmed to get to stress levels that we did in the second wave. And it's been through a focus on therapeutics and using therapeutics early that changed the course of the disease, where patients come in and they're out of hospital within 3 to 4 days, compared to the past where people sit in hospital for a week or longer because it was taking too long for the disease to recover. So that would be my contribution to the discussion. Thank you.
Thank you very much, Prof. I think some of the protocols would need to go to the drawing board so that we have discussions and we also have consensus where possible based on the data that is there and the experiences. Indeed, one of you, I think, said there's no one who knows everything about COVID. We all are on a learning curve yeah, including what type of patients would respond better to what therapy. I've also had to deal with supporting a lot of families who have their loved ones at home and who are refusing to go to hospital. And there's been lots of different treatment protocols in homes, but some by not even qualified medical practitioners, including vitamin drips and all sorts of protocols. So I think we need to surface all these protocols and reach some consensus and use the best available evidence to be able to assist communities and our patients. Thank you very much. Professor Luvengo, can I hand over to you as we call Professor Rudo Mativa to share with us how do we move forward into the future. Professor Rudo? Is she here?
I am here.
Thank you, thank you.
I was even starting to doze off because you put me on the graveyard shift. Thank you very much for inviting me to this session. I got given a list of topics to talk on, but a lot of them have been touched over. What are the key learnings from the first, second, and third wave? I think the first wave, we walked into it unknowingly as brave soldiers, ready to conquer. As infectious diseases, led by infectious diseases specialists, we quickly realized that we needed more than that. We needed isolation facilities, we needed quarantine facilities, we needed intensive care units. We got on top of that. The second wave came. We were almost experts. Then we made a big mistake. We thought we were on top of the disease. We shouted from the tops of the hills as clinicians and said, the disease is not going away. But the authorities started dismantling quarantine facilities, downgrading things, and you know how that ended. The disease came back. Already at that time, we were worried because we already had a variant of concern in South Africa, but we thought we understood its behavior. But we already had warnings about the Delta variant from India. And as soon as Gauteng took off, the wheels came off. Charlotte Maxeke Johannesburg Academic Hospital was out of the picture. And then we realized what we had always been talking about, the weakness and the deficiencies of our public health care sector, that we do not have enough resources, the business processes and systems are not sufficient, and that, hey, we don't actually have such a big private healthcare sector to service such a disaster. So we could have never prepared for this third wave because we never factored the Delta variant into the picture. The question is, what can we do to reduce morbidity and mortality going forward? The one lesson we've learned is to identify the comorbidities that give us a bad outcome in patients with COVID. We can start today addressing those at public health level, borderline obesity. Treat the diabetics very strictly. Treat that hypertension very strictly. Do not drop the ball with non-COVID patients. Just keep at it. Don't forget them. I'm trying to keep it short. What should be done to reduce the COVID fatigue? We are not suffering from COVID-19 fatigue. We are suffering from human fatigue. This is normal. When you are constantly stressed and stressed and stressed, and the stress is never eased off, you get tired. I'll tell you my personal experience. I had COVID infection twice last year. The first infection was not so bad. The second one landed me in an intensive care unit for 7 days, 5 days in a high care unit. I came out. Baruch Hashem, I lived. I went back to hospital to work at Chris Hani Baragwanath Academic Hospital. And I worked and worked and worked. And it's not just working. You are working, you are watching people die in front of you, you are watching people not get beds, you are hearing that the other hospitals are full, you are hearing that members of your extended family are dying. Just from the beginning of this year, I have lost 20 members of my extended family. I do not have a minute to stop and grieve and mourn and process. I am working. And I want to tell the National Department of Health, all the provincial health departments, that you should actually consider yourselves lucky. You have great healthcare workers. Not a single day did they walk off and walk out of their working environments because they were dealing with COVID. They are not having COVID fatigue. They are humans. They are just humanly tired. They have got post-traumatic stress disorder. They have never had debriefing sessions. They have never been offered psychological therapy. Nobody has ever come to any one of them and said, you're doing a great job. When the media press releases are given, nobody opens a statement by saying, oh, thank you so much to our healthcare workers who are forever there looking after our patients. Nobody does that. Nobody appreciates them. They need to know that they're appreciated. They will get up every day and go to work. They watch their colleagues die. They still come to work. They are morally injured and they are exhausted. It's not COVID fatigue, and it's not COVID fatigue in the community either. Those people are just tired. We're all just tired. We're just fatigued. It's not COVID. The virus is not making us tired. We are just human behaving normally. I'm finishing.
Thank you, Prof. Thank you.
We cannot prevent the fourth wave. We are well on our way to it. And no other modalities of healthcare provision will help you deal with a pandemic like this. As you saw, even the well-developed countries were not able to deal with this pandemic in the beginning. Thank you very much.
Thank you very much. Thank you very much, Prof. Well presented the message. We had the message. We're going to do better. And now I'll ask Dr. Bandile Masuku to just check if there were some key questions. A lot of them which are not answered, we will collate them and provide answers. Dr. Masuku?
Thank you and good evening. The graveyard shift is always a problem. I hope I'm audible. I'm just going to make a few points, which I'm hoping that they will be less than 3 minutes. The issue is about looking at the future. What the pandemic has given us as a lesson, a very strong lesson, it's about how our system is and how it's structured and how it should look like. And I'm taking this point from the point of view of the national health insurance and what should be done, because that's the context of our future for the healthcare system. So what COVID-19 has done for us has actually brought the agency on how we need to restructure and reconfigure our healthcare system in terms of what it should be in the coming future. I think the issue that relates to the human resource production and the human resource provision deals with a lot of aspects. It deals with increasing our capacity to train nurses. It deals with the issue of increasing our capacity to train enough doctors. And it also deals with the capacity of us creating new cohort of healthcare workers. And I think we should take that lesson moving forward, and also meaning that the issue of staff shortage, it has become more pronounced because of COVID pandemic. The issue of staff fatigue and staff morale came very much more pronounced. I think what Prof. Mativa have said now just indicates that point. So for us means that as a country, we need to focus and concentrate on producing producing more healthcare workers, and also making sure that we create new, in terms of task shifting, creating new cohorts of healthcare workers. The second part of the lesson is that the basics of everything, which is primary healthcare, becomes so much important. You know, if you listen to the people who, the colleagues who have presented from the side of districts and primary healthcare, including our general practitioners, it talks about how we need to structure our healthcare system at the primary level in dealing with issues relating to prevention we all know it is the same old adage that we all know, that prevention is always better than cure, and prevention is always cheaper actually to do. So the non-pharmaceutical interventions from the messaging that we have put across spoke about how we need to prevent these illnesses and these actually diseases. And I think the COVID-19 has actually made more pronounced and made us more aware that we need to do and focus more on primary health care. The third aspect is just, the last one is just about the issue of infrastructure that we need to provide more. And I think these are areas that from the policy aspect and the future we should look at. Thank you, Prof.
Thank you very much. Can I now hand over to the leadership? To the leadership was listening, and my co-chair is going to ask them just to indicate what they've heard. Comrade Gwen, Dr. Ramhope.
Dr. Bamford, a few words from you as you introduce Dr. Poppy Ramathuba, and immediately Dr. Ramathuba, please introduce the minister to us. Thank you.
So thank you very much, Chair, and good evening to the Minister, the MECs, and all the healthcare workers who have spoken, I think, very eloquently this evening, and often very much from the heart. I think our role today, and I am today representing the National Department of Health, has really been just to listen and to hear from frontline healthcare workers. I think one of the last speakers spoke about how grateful we should feel to our healthcare workers. And I think that's both very true and something that we are very aware of. Currently, I am predominantly working on the vaccine rollout, and it really has been astounding how our public sector colleagues in the provinces have delivered on everything that we have asked them to do in terms of the vaccine rollout. There's no doubt that we face a very challenging situation where we are addressing the COVID pandemic. We are also very conscious of the need to maintain our essential health services, that we can't allow the gains that we have made in terms of maternal and child health. We cannot, and TB and HIV, these core programs, we cannot afford to lose the gains that we have made. But at the same time, we need to be addressing the COVID pandemic. And of course, now we need to be focusing on the vaccine rollout. So I think that's really all that I want to say. I think I've listened. I agree completely that it's going to be very important to document what we've heard today. There are a number of themes that have been coming out around the health system, around the need for healthcare workers and more healthcare workers, better trained healthcare workers, and then a number of really very innovative suggestions about how we could do things better. So I think we would look forward to both engaging in fora like this in the future, but also to make sure that the lessons learned and the recommendations are adequately documented and disseminated. And perhaps with those words then to hand over to the MEC for Limpopo, perhaps just to acknowledge that I've already said that we've been astounded by all the work that has been done by the provinces in terms of the vaccine rollout. And I think the province that has really astounded us more than any has been Limpopo, the province that is really leading the way in showing us how to reach our communities with vaccination. So with those words, let me hand over to the MEC. Thank you.
Thank you very much for those warm and kind words. Special thanks to the two program directors and the host of this event and for this invitation. As a province, we really appreciate that. I must indicate that indeed sitting here and listening to those who are the real frontliners, whom in our province, we always refer to them as the last line of defense. They can't just be your frontliners, because when you're steaming, when all your alternative medicine, all your herbs, all your prayers, when everything has failed, you need this team of health professionals to be your last hope. If they say it's over, nobody else can come and reverse their decisions on your life. Can never be reversed. Their mistake can never be corrected. So that is why it has been humbling to listen to all those inputs, which very much educating even to us. And I want to support most of the views that have been raised by colleagues here, especially on the lessons that have been learned. We really appreciate, and I want to single out the contribution and by Dr. Confidence Moloko, especially when he summarized our response to the pandemic, which from the beginning, why probably we find ourselves here where we are. Yes, we all acknowledge this has been a novel virus which we knew nothing about. Whether you speak of scientists, politicians, all of us were learning as time goes. But any pandemic, its basic was you're supposed to be proactive in terms of your approach. And we at least had an idea from the beginning, learning from the China. Maybe as Limpopo, we were fortunate to house the Wuhan. At that time, we were called names. When we host the Wuhan repatriates, it made us to grow faster, study about this virus, to understand how it's being managed, to say the secret is on screening, it's on testing, it's on tracing, it's on isolating, it's on quarantine. That's why you'll remember in the beginning, we came up with rules that we are going to quarantine cases, because there, if you have one case and you quarantine that case, it will not spread to the next person. Of course, it was received, it had backlash when doctors were forcefully quarantined, and mainly because when they tested positive, they acted irresponsible and tell their nanny to go home to a squatter camp, which we were very worried on the community spread. So it was nothing personal. When a young man from Gauteng test positive and he get into the taxi and he was found in a shebeen, we had to quarantine him forcefully. And I remember the Minister of Coxta was taken to court several times on these issues. We were also taken off quarantine. So that those were some of the basics that we should in future strengthen: the isolation and the quarantine and the tracing as we deal with the pandemic. And we also believe that we have learned from COVID-19 that even other conditions can be addressed, especially as a province. Prof. Rudo Matiba has raised that we, during the, and many other colleagues, in this past 18 months, a number of people we might not have lost probably during the second wave,
but these are patients on chronic medication, your hypertensive, your diabetes, but they were not taking treatment because of all sorts of stories that were told about hospitals and clinics. And we did not strengthen our CCMDD program, which could help them to access medication. That led into many defaulting treatment. And when the second wave came, unfortunately, their immune system could not stand it, and we lost them. So this approach on the pandemic, we believe that social mobilization should happen, not just on COVID-19, but in all other diseases that we are dealing with as a nation, as a country. We should put a powerful mobilization system at all levels, starting with the household. Because when you say the health system has failed you, you start with yourself as an individual. If I'm not living a healthy life, I'm not eating healthy, I'm not exercising regularly, I am smoking when we are saying don't smoke, I'm drinking alcohol excessively, I must expect that I'm failing my own health system. Because that's why we are a department of health, not that of disease, which simple means ours is to look for people who are healthy and help them keep their health status. If we had a healthy nation, the pandemic would not have dealt with us the way it had. But unfortunately, we had a nation that was found wanting when it comes to individual health profile. So it should start at that level. It should move to the community that the person resides in. It should also move into, then you can start to say, I was now failed by my clinic, I was failed my hospital, I was failed my tertiary and my academic. And that, I think, will be the whole approach, even when we are dealing with the national health insurance, to say more investment on our health system must be on the individual, to say your health is your responsibility. It starts with you, it goes to the community, it then goes to a primary healthcare setting. We'll put much more resources there before we think about academic center. Mostly when we're dealing with COVID, we were worried in terms of preparedness, like even now, when we are saying, are we prepared for the fourth wave? More emphasis is on, are we having how many ventilators, how many oxygen, how many? Yes, it's good to have those, but where is the emphasis on how do we deal with COVID-19 as individuals, as communities? Because if we don't win fighting the pandemic on the community, winning it in ICU, we have had all the presenters, we were found wanting because we thought we could hire more specialists, which were not even there, and you can't produce them on a day. So I think I've taken home the issue of us not being hospice-centric in our approach, but become proactive. And I want to congratulate Dr. Maggie on the work that they are doing, Maggie Mujapilu, as a collective, especially supporting the families of the deceased colleagues. And as a province, we launched what we called Psychosocial Hub. This, we had all our mental health professionals from last year to help each other. One of the issues that I can advise also, which we found it working, is that each and every health worker be your brother or your sister's keeper. You know that Poppy is talkative, Poppy is whatever. If one day she starts to be mom, she doesn't talk, she's being withdrawn, you should know that she's not coping. And you should be the first one to be able to deal with that and assist her by getting her help. And our managers, we are also teaching them that we should not jump to final return warning and all that. When somebody is coming late to work, whom we know was a very hardworking, we must start to worry about the mental health and the knock and the stress that what is COVID-19 is doing. I will also appreciate, will communicate with Dr. Maggie to get the story of this doctor, because we as a province, we're very clear, and we work with our private hospital. There's no healthcare worker who could be returned from any hospital or die in an ambulance. We don't have such. I just try to verify, but we'll deal with it outside, because if it has happened, it must never happen. We created even beds, ICU beds in casualty of Netcare, I do rounds there to realize that we can never afford to return any healthcare worker or even any patient without giving them any bed. So let's be the brother's keeper and work together. And I really appreciate, and it's on that note that the person that I'm going to invite to come and speak with us does not require introduction, especially in the health system. I think Dr. Vandile was raising issues of infrastructure, and it reminded me when we were still students, she was a minister of health, our first our first democratic minister of health, whose role even today we still celebrate. She worked very hard during the first 5 years to amalgamate and collapse. I'm not sure if there were 14 or 15, I can't even remember, departments of health, moving from, there was a vendor department of health with its minister, Nebua, Gazankulu, Kwandebele, and Putatswana, and all those departments managed to collapse them and create one national department of health with 9 supporting provincial department of health. And that work, I think, should have been followed. We must admit on this one, as comrades who have been leading this particular department, it should have, and this country, it should have been followed, the work that she has done by upgrading infrastructure. Because if now you open Luitrichat Hospital to start accommodating people from Chiwabsiko and Madombija and everywhere, Prof. Rubengo knows, is familiar of that area. This is a hospital which was meant for only the few Boers who used to reside in Luitrichat town. Now you expand its accessibility to all the rural areas, but you don't invest on the infrastructure. This is where we are found wanting, even now when Makado becomes the epicenter of COVID-19. A lot of work still need to be done. We must pick up on that work to say, when you open Fort Trekker Hospital to everybody, you must also open up the infrastructure and make sure it accommodates not just the population that is growing, but also the people that were previously not accepted there. She has worked very hard. I think we all are still celebrating the benefits of tobacco today because of that work that she has done. And we know that even in the continent, that she's got a footprint there. As the chair of AU, we also know that in this country, she has headed many ministry, and we know when she was in Home Affairs, wherever she is deployed, she always make us, those of us who always look up to her, to feel ourselves very, very proud. So we remember how when she was in health, has been always advocating for us to work with the community. Perhaps I must also share, because speakers are asking, how did Limpopo get a vaccination? Well, we get it because we work with the communities. When we started with the above 60, we look at who is the role model of the above 60. It was religious leaders. That's why you saw us vaccinating them. Not an easy task, very difficult, but we had to do it. We move to the kings and the queens, and we move to people that the people believe in. They don't believe in doctors. They don't believe in politicians. They believe in their own community leaders. And even now, when we get to the above 50, we look at the soccer stars and owners of clubs. When we move to the 35, we are looking at bikers and media houses. When we go to the above 18, we are going to look at Makazi, King Munada, and Master KG. So that is the work that you need the third party to talk about the work you do. If you want to do it on your own, no matter how brilliant you are as a scientist, you'll never win the people. People have their own leaders that they believe in. So colleagues, let me present to you our mother, Mama Nkosazana, Dr. Nkosazana Dlamini Zuma, our current Minister of Kokta, who is also and has been a member of National Executive Committee and the convener of the Subcommittee on Health and Education. All these issues of health, we learn from her, most of them. And Mama Nkosazana, these are your some are your colleagues, some are your children who want to get comfort from your word. I'll hand over to her.
Thank you very much, Poppy, and thank you to the core program directors, Prof. and Gwen. And I must say thank you to all those who have participated and who have spoken. We have listened very carefully, and I won't say a lot because I was briefed by Gwen that I'm invited to come and listen. So I did listen, but let me just say, I agree with Prof. Rudy that maybe we do not say and we do not recognize and acknowledge the health workers enough. Indeed, they've really been fantastic, I must say. They've shown what Ubuntu means because they've worked sometimes day and night without rest. And I know it for a fact because I've had relatives in hospitals and being taken care of. And I know some of them don't even take days off. And they've shown Ubuntu in the true sense of the word. And I think we really need to acknowledge that. Not only in the hospitals, the GPs, and all the health workers across the board in the private sector, they've all done a fantastic job. And they are still continuing. And of course, they are saying categorically the fourth wave is coming. So it means their services are going to be needed. And one of them said, we say they are resilient and innovative. Indeed, they've been resilient and innovative. But he also said we mustn't take this for granted. And we are not taking it for granted. We really are not. And we have also heard that health workers, I'm going to talk more about health workers because they've been talking more about patients and talking about us. That they've had a lot of issues, mental health, well-being, because of the hard work they've had to endure. At least seeing their colleagues passing away, leaving families, but also patients, losing patients to a disease that was really not known. And I think one of them...
I want to do this.
Dr. Nancy, please mute. Thank you.
And one of them was saying we should pay more attention to their mental health, to their well-being, and I agree with that. We need to pay attention to that. But I also must say that I completely agree with the fact that we must support the young health workers. I think it must be very traumatic for young health workers who are starting to work in this profession during this time of COVID. And I think they do need supporting. And I agree also with Dr. Meg that we must honor those who have passed away on the job, like they've died as soldiers. And we must also not forget that they have families that they've left behind. And we need to look at what is it that we can do and support the work that they've already started and maybe work with them to do more. I also appreciate everything that have been said about communication, about not being hospital-centric, because primary healthcare can do a lot more testing, tracking, tracing, and also they can also, because they are amongst communities, be able to diagnose patients earlier and send them and give them treatment and send them for treatment appropriately. So I think it's important to recognize that. And there are positives that have come, that have been mentioned, like the good collaboration between the state and private. But there are also suggestions that maybe we should reinstate the joint posts with universities, need more trained nurses and of course, general health workers, doctors. I will take the message about what the DPSA directives have been saying, which do not have specification for health workers. So we will take that message home. And of course, we recognize also that what has been said about the challenges of saying patients must isolate. How do patients who live in one room, who have one room, isolate, or even two rooms? An entire family, it's just not possible to isolate, and I agree with what the doctor that has raised that. And it was for that reason, I think, that quarantine sites were established to deal with that difficult situation. I think also the issue of comorbidities and other chronic diseases that have been kind of neglected because of COVID, but they also contribute a lot to the mortality, like obesity, diabetes, hypertension, and so on. So I think it's something that we have to pay attention to, as been said. Of course, improve the vaccine rollout. True that Limpopo is doing better than the other provinces, but all the provinces are trying, and I think there was an indication that doing 300,000 a day is not enough. We should try and do more. And it's true that everyone is just tired, humanly tired. We agree with that at various levels. But I won't say much because the people who are in the health sector have spoken. For us is to appreciate, and also we will take some of the lessons. I took quite a lot of notes. I think when we are in our health committee, and Dr. Confidence said a lot, but we will look at everything that has been said and see what needs to be taken up by government. I think Dr. Bandile has also mentioned infrastructure, and even Dr. Bobby has mentioned that. So we will take what needs to be taken up with various levels of leadership at the provincial and national. But I think for me, it was a very interesting session to just hear what has been learned, what has worked, what hasn't worked, and what we should be doing. So I just want to thank you very much. and hope that at the next session, maybe some of the MECs and health workers can share a lot more about what their response is to what has been said and what we may plan to do. But I hope that the fourth wave won't be as bad, but we should heed what has been said and do what we can do to at least try and lower the mortality that we've seen in the third wave. And I agree with the doctor that says we must try and keep the emergencies as few as possible so that we open up space for other patients. But it's a pity that he then says, which is true, he's just telling the truth, that when we do open up, we seem to make up for the lost time, and then the emergencies become even more. So I think it's something that we should pay attention to also in our communication. And I agree with him in terms of advertising. Can't we deal with some of the advertising of alcohol? Because to young people, it seems like it's the coolest thing to do because they see the adverts and we're not like the Cubans. I once saw a program in Cuba that was teaching young people how to watch TV. And I said, how you're teaching them how to watch TV? And they said, yes, because when you watch TV, and they said because the satellite TV was coming and they will have no control over what the young Cubans are watching. So it's better to teach them how to watch TV. And they said, if you watch something passively, it influences you. If you watch it and you interrogate what is being said in your mind and you interact with it, you are not easily influenced. You are able to separate what is real and what is not real. But if you just watch it passively, it tends to influence you. And I think with alcohol and other things, we do need to maybe get our kids to watch those adverts in a more critical and analytic way than passively. But the night is, it's late now. I won't say much. Thank you very much. I hope that we can have these discussions, not only about COVID, but just about how to build a better health system, how to deal with our communities in a way that they understand healthy lifestyles and so on, but also just to appreciate our health workers. So I hope this is not just the beginning of these interactions, but it's the beginning and we'll continue with them, not that we will end with COVID. Hopefully COVID will end, but these interactions shouldn't end because it will help the departments as well as communities to improve our health system. Thank you very much and good night to everyone.
Thank you very much to our leadership in the health system, as well as Menkosazana Dlamini Zuma, for staying until now and being also attentive and being able to be responsive as well. Prof, as I hand over to you to, I think we've got Professor Mhla, to just pull things together. I want to hand over immediately after that to Prof. Luvengo. The challenge is how do we, translate this sharing, this experience into information, from information into knowledge, and from knowledge into solutions. The commitment, especially from the two institutions involved, which are also state supported institutions, which is VETS and UP, we should be able to find ways and means of making a contributions to supporting the Department of Health and government efforts, and indeed supporting our health workers in the front line of the battle against COVID, but also the battle against disease, and have evidence-based practices and policies, but be prepared for any eventualities such as we are dealing with, like COVID. Thank you very much from my side. It has really been an honor to share, for you to share with some of us, and we can only commit to work together going forward. Prof. Mtla, and then over to you, Professor Luvengo.
Good evening, chairpersons, Megwen Ramahopa and Professor Tiveli. And good evening to the leadership and all protocol observed. It becomes very difficult to speak after the leadership of the movement has spoken. So therefore, and also when it is so late in the evening. So therefore, what I will do is just to highlight some of the things that I think our meeting today has brought to the fore. And it becomes very critical that as we go forward, we look at how these are either minimized or we shall hear of them no more. Yes, we have heard that we need to protect the essential services despite the might of any pandemic. We need not be hospice-centric in anything that we do. And as some of, and most of the speakers have shared with us, that it becomes imperative that as a country, we need to go back to the basics and to strengthen the health promotion and disease prevention. And we've heard that some of the lessons that have been learned from both the first, second, and current third wave is a question of multidisciplinary teams. They become very important. We have been assured by the leadership that yes, the political will is there to assist all and sundry as we move forward. We've learned from some of the experiences amongst our critical care colleagues of what they did best and why, in some instances, our country has become amongst the first in the world to manage some of the problems that we faced with during the pandemic, like appropriate triaging and managing those patients that will surely survive. We have also heard about the changes that may have led to the current pandemic in terms of the phenotype of the disease as well as the severity of the illnesses. I'm not going to go through some of these. I will share with both of our colleagues. Then it also has been very important that in the management of this pandemic, we have had various ways of looking at how we can minimize mortality, even if we may not agree, because we do not have universal guidelines. But however, from the anecdotal experience of some of our colleagues, we can see the difference that these have made. We have been rudely reminded by Comrade Konfi, as well as Mujapilo, that we need to look at some of the things that can strengthen and make our colleagues feel appreciated. And this is very important that we look at the mental health challenges and the need to consolidate and no fragmentation as we look at some of the challenges that we face. Yes, we have also been told from the virology perspective of the good clinical data that the vaccination has in some of the countries. There may be a problem in terms of reaching the target population, but I believe that all is not doom and gloomy. We will achieve. And we also have been told from virological perspective of the importance of surveillance programs. And yes, we have been told the successes in Limpopo province. And also what to me has been very, very, very eye-opening and also reassuring was the fact that this meeting has been very diverse in that it covered some of the provinces. It covered Limpopo province, we covered Gauteng, we had something from the Free State, and we had something from the Eastern Cape as well. And to me, it shows how the leadership, especially those who coordinated this meeting, have been all-encompassing. I think with those few words, I will hand over to Professor Luengo.
Thank you very much, Prof. And thank you very much to the Minister. And thank you very much to the entire leadership of health in the provinces and national. You know, the meeting has gone so well. If I can tell colleagues that this meeting was planned this Sunday, and we managed to put something that is very successful. And we also got assistance from Dr. Nyati, Fundila Nyati, and with Siviwe. And this program was finalized. The major part of it was today, and getting assistance from Dr. Nyati was yesterday in the afternoon, late in the afternoon, at 5 o'clock. I was still around Johannesburg. Thank you very much, Dr. Nyati. Thank you very much, Siviwe. It really, you have made a mark. We've seen excellence. And just to respond to what the minister said, this is the beginning of frequent meetings. Some of us were saying, Minister, give us the NHI program. We want to run with it. We are ready for it. And indeed, this is a platform that we're going to use to try to drive some of those programs. So apologies for keeping everyone too late, until late, but thank you Thank you very much. South Africa is proud of you, all of you. Thank you. Have a wonderful night. Thank you.
Onto that.